Good evening. Good evening. On behalf of IADVL Tamil Nadu, I welcome you all for the World Vitiligo Day observation. Today's the vision of this year is looking into the future. Now I request Dr. Kalishwaran sir, the President of IADVL Tamil Nadu, to give the speech. Thank you.
Yeah, thank you, Dr. Jaini. So, good evening to all. I first of all thank our entire EC and the speakers for accepting to be in this meeting. As we thought that it would be nice to have this meeting on Sunday, we postponed this Vitiligo observation day to this Sunday because last Sunday and previous Sundays from National IADVL they had a lot of meetings. So to avoid the overlap, we just observed this Vitiligo Day meeting on this day. Here we are having three speakers. Dr. Vijay Anand will be talking on medical management, and Dr. Sundari madam will be talking on phototherapy, that Excimer. And we all know that our well-known the doyen in vitiligo surgery, Professor Ravichandran sir, will be talking on surgical management. He has started vitiligo surgery almost 2 to 3 decades back, and he is a pioneer in vitiligo surgery and the first one to start that vitiligo surgery in Tamil Nadu. So really, we are happy and glad to receive Ravichandran sir in this meeting. Welcome, sir. And I equally also greet all the speakers, Dr. Vijay Anand and Dr. Sundari. And also Dr. Parthiban from Madurai will be joining with us for panel discussion. I hope all the members will enjoy this session of Vitiligo CME and make use of it. Thank you. I thank all the EC members and IADVL members for attending this CME. We can start the CME now.
Thank you, sir. So we will begin the first session with Dr. Vijay Anand sir speaking on the medical management of vitiligo, the difficulties and the long-term view that we need to have when we look at our patients. Over to you, sir.
So, Vijay sir, kindly unmute yourself, sir. Dr. Vijay sir, kindly unmute yourself. Vijay sir, unmute yourself.
Yes, as you all know, vitiligo is a disease which is always a frustration to the treating dermatologist. Many times we are not able to find a complete curative treatment. It always goes with labs and remissions. So in this PowerPoint presentations, I have tried my best to address certain issues related to this pathogenesis briefly, and what are the conventional treatment right now we are using, and what are the treatments in pipeline in the near future. So I start with the first slide.
So you can move to slideshow, sir.
Yeah, 1 minute.
Right, that one only, sir. Please select that.
Yeah. So we start with this introduction. Vitiligo is an acute depigmentation disorder due to progressive destruction of functional melanocytes in the epidermis, in the follicular reservoir, and the mucous membrane. Clinically characterized by asymptomatic circumscribed depigmented macules and patches. So when you take that biopsy, one important finding is that infiltration of the cytotoxic CD8 T lymphocytes at the site of lesions and also at the border of the lesion. That is the important hallmark histopathological finding of that vitiligo. In stable lesions, the number of lymphocytes is minimal, whereas in active lesions, it will be more. So coming to the etiology, so the patient will always have some genetic predisposition set up any environmental stress factor, maybe an infections or even a drugs or an oxidative stress that will trigger the autoimmune response against the melanocyte, that causing melanocyte loss, leading on to the depigmentation of the skin. So coming to the pathogenesis, as I said earlier, any stress response in a genetically predisposed individual, so that will trigger that unfolded protein response that may activate some pro-apoptotic gene that may cause apoptosis of that melanocytes. Similarly, the stressed melanocyte may release the heat shock protein, and which may bind with some innate melanocyte antigen, pre-melanosome antigen, and that may act as a happen, and that may be recognized by that inflammatory dendritic cells, which will present this hapten to that CD8 T cells, and that may cause melanocyte loss. Or this heat shock protein may bind with the plasmacyte dendritic cells, which may release interferon alpha, type 1 interferon. So that may either stimulate the keratinocyte to release the CCL10, which is a chemotactic factor for CD8 cells, or that interferon alpha further stimulates the inflammatory dendritic cells, which may activate the CD4, which releases gamma interferon, and which may activate the keratinocyte, which subsequently releases the CCL10, and that may recruit the CD8 cells. So these combined together cause that melanocyte apoptosis. So the two important cytokines involved in the pathogenesis of vitiligo is gamma interferon, that we should never forget, and of course TNF alpha has some role in sustaining this apoptosis by upregulating certain adhesive molecules on that apoptosis. So in any highly active vitiligo, active stages of vitiligo, the patient will have elevated levels of gamma interferon and CCL10, not only in the stimulations but also in the circulation. And some of the cytokines which downregulate these events include this interleukin-10 and transforming growth factor beta. Both these factors are downregulated because these two are produced by the Treg cells. And in vitiligo, this Treg cell is suppressed, and with decreased levels of interleukin-10 and transforming growth factor beta. So when you take the disease course, if you take that non-segmental vitiligo, it rapidly spreads and then stabilizes for a few months to few years, and again reactivation takes place. Whereas in segmental vitiligo, the disease is stabilized within 2 years of onset. So our treatment objectives should be, first we have to arrest the ongoing activity, so to halt that melanocyte loss, and we have to regenerate that melanocytes. So for that we have to induce the differentiation, proliferation of that melanocyte in that surrounding skin, intact skin, or the melanoblast that reservoirs in the hair follicle, and we have to prevent the relapse. So for this, we have to address three important factors. One is that autoimmunity, and other one is this, we have to reduce the melanocyte, stress, for which we have to use antioxidants, and we have to enhance that melanocyte regeneration, for which we have several armamentarium of treatment before us. So coming to the treatment of vitiligo, so that can be classified as a medical and surgical treatment. So under medical, we have various topical treatments. Mostly we use topical steroids and calcium inhibitors. Of course, there are some other topical treatments also available, which include this vitamin D3 analog, that 5-fluorouracil, and topical creams with the pseudo-catalase and superoxide dismutase activity. And of course, we have tried human placental extract and fibroblast factor decapeptide solution is also available. And recent addition to this treatment is topical Janus kinase inhibitors. And phototherapy, we have that commonly we use the PUA therapy and narrowband ultraviolet B therapy. And for localized vitiligo, this Excimer laser is an exciting option. So under systemic treatments, we have commonly we use systemic steroids for arresting the progression. And of course, we can also use these conventional immunosuppressives. And of late, we have this new addition to this, the targeted immunosuppressives. Again, that is that systemic Janus kinase inhibitors. And in extensive vitiligo, we have no other option. We have to go for depigmentation of the wilderness patches, for which we use certain bleaching agents. like monobenzyl ether of hydroquinone, monomethyl ether of hydroquinone, and 88% and we can also use ruby and alexandrite basin, and of course cryo can also be tried. And for social gathering, we have to use this camouflage, and of course we have to always advise the patient that they have to regularly use sunscreens, because that vitiliginous skin is more prone for sunburn. And surgical options for segmental vitiligo and vitiligo involving focal vitiligo and some mucosal vitiligo, we can go for certain surgical, which will be discussed in detail by our sir. So coming to the treatment selection and response, so this is influenced by various factors. So regarding treatment selection, age is an important factor. We cannot use certain treatment that children, we cannot use children, and this Janus kinase inhibitors approved only about the age of 12. And comorbidity, there is some associated comorbidity, then naturally that will also influence the treatment factors. And cost is very important one, and we cannot use high-end treatment in poor resource settings. And similarly, accessibility, that is also important. For poor therapy, they have to regularly come, and tier 1, tier 2 cities only it is available. And type of vitiligo also influences. Mucosal vitiligo, the treatment outcome differs, and treatment of choice also differs. In segmental vitiligo, naturally we have to go for surgery. And site, again, is influencing this treatment. The extent of vitiligo also influences treatment, choice of treatment, and disease activity. So in active vitiligo, we have to rapidly arrest the progression of the disease. So that will also affect that treatment choice. Similarly, response to that treatment also is influenced by various factors. In general, the children respond to the treatment better than adults. And type of vitiligo is stable focal vitiligo responds better than a generalized vitiligo, and mucosal response always is resistant to the treatment. In general, lesions site also influence that treatment. Lesions of the head and neck respond better than the acral areas, and localized vitiligo respond better than that generalized vitiligo. And long duration of disease also affects the treatment outcome. And this punctate form of vitiligo and leukotrichia, they also are markers of resistance to the treatment. So in general, the medical treatment of vitiligo is dependent on the presence of melanocyte reservoir, and is effective only in 60 to 70% of the patient. So regarding the treatment response, we usually, the response is measured as a mild if it is less than 25% repigmentation, moderate is between 25 to 75%, and marked repigmentation is above 75%. So coming to the topical treatment, so commonly we use these topical corticosteroids and topical calcineurin inhibitors. So corticosteroids, topical corticosteroids are the first line of treatment in extrafacial vitiligo. It can be either used as a monotherapy or can be combined with this phototherapy in generalized vitiligo. Commonly, we use these class 3 mid-potent topical steroids, which have poor systemic absorption, less atrophogenic potential, like mometasone, methylprednisolone, and fluticasone. They are safe and effective. And there are no guidelines regarding the optimal duration of the therapy. So in general, they can be used daily, once daily for 3 months, or 15 days per month for 6 months. And they can be also combined with this vitamin B3 analog and narrowband ultraviolet B therapy, so that will enhance that repigmentation, and the response will be also very quick. And cyclical treatment with the topical calcineurin inhibitor can also be done. And in general, the response with topical corticosteroids, nearly 50% of people, treated people, have more than 75% repigmentation at the end of 3 to 6 months. So response will be better naturally in sun-exposed areas. And in dark skin people, the response will be better. And recent onset lesion will have always a better outcome compared to the long lasting lesions. So mechanism of actions, as you all know, this this topical corticosteroid, they suppress that CD8 cytotoxic cells, and they also suppress that antigen presenting cells like Langerhans cells. And regarding the side effect, local side effect, we all know that atrophy, telangiectasia, and hypertrichosis, acneiform eruptions. Sometimes even we have seen over vitiliginous patches sometimes this dermatophytosis because of the extensive use of topical steroids. Systemic absorption is a likely one if there is continuous prolonged treatment and treatment over large areas or over thin skin, particularly in children. So coming to topical calcineurin inhibitor, this is the first line of treatment in head and neck vitiligo. So mostly we prefer tacrolimus over pimecrolimus, and 0.1% is used. So it is applied twice daily. Duration of treatment mostly for 6 months. But it is not that much effective in extrafacial areas where we have to apply it under occlusion. And nearly 50% of the people achieve greater than 75% repigmentation head and neck areas. But response in focal vitiligo and vitiligo vulgaris is better when compared to this segmental and acrofacial vitiligo. And again, dark skin patients, they respond better, and recent onset lesion will have a better outcome. The only side effect is pruritus and burning erythema. That is only transient. When if you continue the treatment, that will disappear. Regarding the mechanism of action, they enhance the melanosomal maturation, differentiation, migration, decrease the degradation of this melanocyte. They also decrease the TNF alpha levels in the skin. So some of the other topical treatments which are currently available include topical prostaglandin F2 alpha analog. So we have this letinoprost and that bimetoprost solution, and they increase the melanin synthesis and increase the melanosome transfer and increase the dendrites. So mostly they have been tried for periocular vitiligo, and 1 drop is applied over 1 centimeter, 1 square centimeter area twice daily. Greater than 75% repigmentation seen at the end of 3 months. And some of the other options include this basic fibroblast growth factor related decapeptide. So this should be applied once daily at night and next day morning sunlight exposure. This has to be continued for at least 12 months. So and pseudo-catalase superoxide dismutase topical creams are also available. They reduce the melanocyte stress. They are antioxidants. And right now, the one topical selective sunscreen has been recently launched, which contains this ethyl hexyl benzoate and alpha glucosyl hesperidine. So this daily we have to weekly thrice we have to apply and followed by sunlight exposure after a gap of 20 minutes. This selectively permits that wavelength which is effective in vitiligo, that is 311 to 312 nanometer. And curcumin melo extract and some of the other tetrahydrocurcumin cream and placenta electrate, they have been tried, but we have very limited validated studies on these molecules. And vitamin D3 monologue as a monotherapy is no longer effective, but we have tried along with the topical steroids in a combination treatment. And 5-fluorouracil, this can be combined with dermabrasion or with microneedling, because 5-fluorouracil increases the migration and proliferation of melanocytes. And that microneedling, the trauma will release that certain growth factors that will again proliferate that melanocytes. So microneedling every once in 2 weeks or once in 4 weeks, followed by 5-fluorouracil application until there is inflammation. This can be tried for 3 months, and particularly in periangular vitiligo, resistant localized acral stable vitiligo. So all these things have been tried only in stable vitiligo. So 50 to 75% repigmentation at the end of 3 months have been reported. Similarly, dermabrasion, ideally with this RBM laser, once followed by daily 5% 5-fluorouracil daily under occlusion. So 50 to 75% repigmentation has been reported at the end of 3 months. So coming to that phototherapy. So phototherapy in general, we use as a first line of treatment generalized vitiligo or in resistant localized vitiligo. So it is more effective if it is commenced very early in the disease. It can be either used as a monotherapy or can also be combined with other topical molecules like corticosteroids, TC inhibitors, and vitamin D3 analog. So it should be at least continued for 3 months for visible effect to be seen. And if the vitiligo responds at the end of 3 months, then we can continue for up to a year. But at the end of treatment, if there is no adequate response, then we have to stop the treatment. in general, there is no evidence supporting maintenance phototherapy after achieving adequate repigmentation. So, mechanism of action, as we all know, this all these phototherapy, both PUA therapy and this narrowband ultraviolet B therapy, they cause apoptosis of all that both innate and adaptive cells in the epidermis. They downregulate CD8 cytotoxic cell, they downregulate natural killer cell, they upregulate T regulatory cells, they suppress the keratinocytes, so thereby decreasing the adhesive molecules, and they decrease the gamma interferon-inducing cytokines, and they also release the prostaglandin E2 and LAG, which will cause melanocyte stimulation. They also increase the level of matrix metalloproteinase 2, which will increase that melanocyte migration, and they also increase melanocyte proliferation, increase the transfer of melanocytes. So commonly we use the options include PUA, topical PUA, PUA sol, and narrowband ultraviolet B, and Excimer. That other things only limited trials we have. So coming to the narrowband ultraviolet. So this is the first line of treatment for generalized vitiligo, involving more than 15% of the body surface area. It can be used also in actively spreading vitiligo to stabilize that vitiligo. So treatment is given at 2 to 3 times a week and 48 hours interval. Starting dose usually, since the vitiliginous lesion is always taken as a phototype 1. So start with the low dose, 150 to 250 millijoule per square centimeter, and then increment of 20% until minimum erythema is achieved. Or we can start with the 70% of that minimal erythema dose. So usually this treatment should be continued for at least 3 to 4 months. Then only we can see the signs of repigmentation. So no consensus on the duration of treatment. Treatment is continued as long as there is ongoing pigmentation. So naturally it may take at least 1 to 2 years. So for maximum repigmentation, you can go up to 150 to 200 sessions. So in non-responders, that is treatment is stopped, you have no repigmentation at the end of 3 months, or less than 25% repigmentation at the end of 6 months, then we have to stop the treatment. For skin phototype 4 to 6, there is no ceiling for exposure. But for skin types 1 to 3, the maximum number of sessions would be limited to 200 sessions. And the initiation and the significant repigmentation is entirely dependent on the total number of treatment, not on the frequency. But repigmentation is faster with the thrice weekly treatment than when compared to twice weekly. And as I said earlier, maintenance treatment is not recommended. So during the treatment, we have to follow the patient, not only for the side effect, but also for repigmentation. After achieving complete, marked repigmentation, patient should be regularly followed for relapse. So relapse rates with the narrowband ultraviolet B is 44% within 1 year and 50% within 2 years. And maximum allowed dose per session over phase is 1,500 millijoule per square centimeter, or trunk is 3,000 millijoule per square centimeter. Regarding side effects, so naturally, you might have seen this narrowband ultraviolet B, there will be dryness of the skin, erythema. Severe phototoxic reactions can also occur, manifesting the form of bulla and burns. And long continuous therapy, prolonged therapy may cause xerosis, freckles, and aging. Very rarely carcinoma has been reported, but it is very rare with the narrowband ultraviolet B therapy. Regarding the ocular side effect, we have that acute photokeratitis, but continuous treatment may cause cataract, AGM, pimple. So we are always advise the patient to wear the goggles while undergoing this narrowband ultraviolet B therapy. But post-treatment, patient need not avoid sunlight exposure, unlike PUA therapy, where the patient has to use sunscreens even up to 12 to 24 hours after completing the PUA therapy. Coming to this PUA, this is the IADVL guidelines for PUA and vitiligo. So it is again treatment only for generalized vitiligo, but it's not the first line of treatment. In adults, it is only narrowband ultraviolet B therapy is the first line of treatment. So this can be used as a second line of treatment, but in children, we cannot use. they can be used only above the age of 10 years because of that associated retinal toxicity. So we always give oral PUA. It is given a dose of 0.8 milligram per kilogram. It is given 2 times a week at 70 hours interval. Treatment should be continued for at least 6 months before being considered non-responsive. So total duration of treatment at least should be 12 to 24 months of continuous treatment for maximum response. So in general, head and neck vitiligo respond better, and the dark skin patients respond better. And the mucosal vitiligo, of the palms and soles and bony palms, they don't respond much better, less when compared to these head and neck areas. So patients with long-standing vitiligo can also undergo this PUA therapy. And repigmentation is noted in 70 to 80% of patients with PUA within 3 to 6 months. And the complete repigmentation is obtained only 20% of the patients. And relapse can occur in 75% of the patients after 1 or 2 years. If no response even after 50 sessions, we have to start the PUA therapy. So the protocol follows either US protocol or that UK protocol. US protocol is depending upon the skin type. So we start with that 2 to 3 joule per centimeter square. Dose increment is 0.5 to 1.5 joule per square centimeter based on that therapeutic response and erythema. UK protocol, we have to calculate the minimum phototoxic dose, and then 70% of that minimum phototoxic we have to start with, and then gradually we have to increase the dose. So the caution is needed. Maximum dose allowed is per session is 6 joule per centimeter square, and caution is allowed while PUA therapy. So photo protection is not required in home or office settings, but sun avoidance is advised to minimize pigmentation from natural sunlight. And we have to advise the patient to wear these UVA photo protection glasses. And the patients should always use the sunscreens and with the SPF 50+, and they have to protect the genitalia. In areas around the genitalia, we have to treat, then we have to use 25% of the ideal dose. So regarding side effects, so mostly systemic side effects are seen with this PUA therapy. May have that nausea, vomiting, and headache, insomnia, hyperactivity. Some patients have reported with fever, tachycardia, and bronchoconstrictions. And cutaneous side effects include like acute side effects like erythema, skin pain, bulla has been reported with long-standing side effect. Photoonycholysis, melanoma, and herpes simplex reactivation we have also seen. And with long-standing, continuous PUA therapy, so chance of photoaging and carcinogenesis is always a possibility. And ocular side effects include that cataract and non-melanoma skin cancer and squamous cell carcinoma also we have seen with this PUA therapy. So, before starting this phototherapy, we should always ask for family history of autoimmune diseases, and then we have to check for ANA levels before starting phototherapy. That is very important. Contraindications, absolute contraindication is certain chromosomal breakage disorders and aggravated dermatosis like lupus erythematosus and pregnancy and lactation. Later contraindications includes photosensitivity and patient on photosensitizing medication, family history of personal family history of melanoma or personal family history of non-melanoma skin cancer, previous treatment with arsenic and ionizing radiation, severe renal and liver disease, and age less than 10 years, particularly for PUA. Whereas narrowband ultraviolet therapy can be given for children and during pregnancy and lactation. So this is comparing that narrowband ultraviolet B therapy with that PUA. So narrowband ultraviolet B therapy can be given to children during pregnancy and lactation. So the treatment response, one advantage with narrowband ultraviolet B is the good color matching between the treated and untreated areas. So in all patients treated with the narrowband, they have good color matching, whereas only 44% of the patients with PUA. So PUA is effective in active state. The patient is having actively spreading vitiligo, we can go for PUA, whereas narrowband ultraviolet B is preferred in a stable state. And while PUA therapy, the patient has to avoid strictly the sunlight because that may interfere with that treatment response. And again, the side effects are also known. The patient may have that phototoxic reaction at sites of sunlight exposure. And narrowband ultraviolet B, the efficacy is higher with less systemic and less cutaneous side effects, and relapse rate when compared to the PUA is less with narrowband ultraviolet B. Come to the PUA. So PUA is the patient has to take that Sorolin and stand in the sunlight. The main advantage is cheap, no logistics required, but the main disadvantages include you cannot quantify that ultraviolet light, and the ultraviolet light radiation is also not uniform throughout the day, and they may be also exposed to that unwanted rays and lack of privacy. So ideally, the patient should stand between either between 9 to 11 or 2 to 3, where the ultraviolet A light concentration is high, or we can use solaria instead of sunlight. And so in general, oral trimethoxysorolin is preferable over 8-methoxysorolin because of that lesser phototoxic effect, and sun exposure is advised 1 to 2 hours after sorolin intake, with the minimum gap of 1 day between treatment. Time of exposure is increased by 5 minutes every week till a maximum of 30 to 40 minutes. And then time can be kept constant. If no improvement even after 30 to 40 sittings, it should be discontinued. Come to the topical PUA. So here the patient is, after taking that sorolin, the patient is, the lesion is exposed to that ultraviolet light in the chamber. So it's ideally used for less than 5% of the body surface. It is not useful in actively spreading vitiligo. So a lower concentration of 8-methoxysorolin is used, varying from 0.01 to 0.1% concentration. And the patient has to apply it over the thin layer over that affected area, and the irradiation is done after 30 minutes. So here dose increment is 0.25 joule every per square centimeter. And then the main advantage is less systemic and ocular phototoxicity, smaller cumulative UVA dose. But the thing is, a patient may develop blistering reactions if he doesn't follow the strict protocol, and always associated with perilesional hyperpigmentation. Again, coming to topical PUA, again, after applying the cream, the patient has to stand in the sunlight, and it is generally avoided because of the greater phototoxic risk. Here we use this 8-methoxysorolin. So after applying this 8-methoxysorolin, after a gap of 30 minutes, the patient should be exposed, the lesion should be exposed to the sunlight, starting with that 1 minute, and then duration of sun exposure should be slowly increased 1 minute every week till slight erythema appears, after which the time is kept constant. Coming to KUA, this is not used now. It is a kaolin, it's a phenochrome compound. That main advantage of this molecule is the lack of phototoxicity. So it can be used daily, less mutagenic, no perilesional hyperpigmentation. It is given a dose of 100 milligram 2 hours before treatment, but main disadvantage is hepatotoxic. It can be also used as a cream form, in a concentration of 3 to 5%. Some of the other phototherapy unit options include ultraviolet A treatment, which is not used in vitiligo right now, and PUA combs for scalp vitiligo, and Dead Sea therapy, nothing but after taking bath the sea water and then exposed to the sunlight, climatotherapy. So coming to that systemic steroids and immunosuppressants, role of systemic steroids in vitiligo. So they are mainly useful in a patient with a rapidly spreading vitiligo. To halt the progression, we have to go for systemic steroid, but they are not very much effective in repigmenting the stable vitiligo. So mostly we give pulse steroids, either beta-amoxicillin 0.1 or dexamethasone 0.1 milligram per kilogram, or methylprednisolone 0.8 milligram per kilogram on 2 consecutive days, or prednisolone 30 milligram per day on 2 consecutive days per week for 3 months. So that will arrest the stabilization, achieve stabilization 1 to 3 months. And it should be given at least for a minimum period of 2 months. If there is no response, then they have to stop the treatment. There is response that can be continued up to 6 months. But main disadvantage is after doing steroid, 40% of the patient relapse within a year. During fast-spreading vitiligo, phototherapy is usually commenced after this intervention. So we start with the mini pulse, and then we put the patient for phototherapy. So that will maintain the remission and prevent relapse. Come to the immunosuppressants. Currently, no sufficient data and evidence available for recommending this immunosuppressant vitiligo. Only few randomized controlled trials and case series. So commonly we use these azothioprine. That's the most commonly used immunosuppressive in vitiligo. That has immunosuppressive effect both on T and B lymphocyte. Low dose azothioprine is very effective. 0.6 to 0.75 milligram per kilogram at least should be given for 6 months. But it needs regular monitoring. They have combined azothioprine with the oral PUA also, but the chances for cutaneous carcinogenesis, we have to look for this combination. And similarly, methotrexate in a dose of 25 milligram per week for 4 to 6 months can also be given. Again, all these they suppress these. They are non-specific. I mean, broad spectrum of action. They don't selectively target. They attack all innate and adaptive immune cells. So again, low dose methotrexate in a dose of 10 milligram per week with narrowband ultraviolet B can also be continued for 3 to 6 months. Some of the other treatments that have been tried include mycophenolate mofetil in a dose of 2 grams per day and cyclosporin 3 milligram per kilogram for 3 months. But commonly we use this azothioprine, and of course we can also use methotrexate. But with other molecules, there are only very few limited studies, not much validated data available right now. So coming to that new treatment, this Janus kinase inhibitors. So the main event in vitiligo is this gamma interferon, cytokine mediated melanocyte apoptosis. So gamma interferon acts through this JAK1 and JAK2 signal transducers. So if we block this thing, I think we can arrest that melanocyte loss. So because this CXCL9 and 10 will not be released, that because these are the two chemokines that recruits that CD8 cytotoxic cell which cause melanocyte loss. So we have both oral and topical Janus kinase inhibitors. Oral tofacitinib, it's now under a phase 3 trial. It has not been approved yet for the treatment of vitiligo. Of course, it has been approved for other psoriasis and alopecia areata and rheumatoid arthritis. And similarly, topical tofacitinib is said to be approved. The only topical Janus kinase inhibitor approved for use in vitiligo is ruxolitinib. It's a Janus kinase 1 and 2 inhibitor. Some of the other Janus kinase inhibitors under trial for vitiligo include oral ritlecitinib and oral upadacitinib and oral povorcitinib. So these Janus kinase inhibitors, the main advantage is they selectively target these CD8 T cells. And coming to the ruxolitinib cream, it is available in the strength of 1.5% cream. It's approved above the age of 12. This can be applied twice daily for 6 months, and response in head and neck areas better compared to the trunk and acral areas. This effective long-standing, that is very important. So in a long-standing vitiligo, we can try this molecule, and this efficacy is maintained through 52 weeks. So they have reported that its efficacy. They have done several randomized controlled trials on this molecule. And ruxolitinib in combination with phototherapy, that gives a synergistic effect, and it is safe and well tolerated, except acneiform eruption. Some of the other topical newer molecules, emerging molecules include this afomelanotide. It's an alpha melanocyte stimulating hormone unlab. So this is tried only in type 3 to type 6 skin and induce melanogenesis and skin pigmentation in the absence of excessive UV exposure. So one pilot study has been done on this molecule involving few patients where they have implanted afomelanotide subcutaneous implant every month in a dose of 16 milligram for 4 months, and then combined with the narrowband ultraviolet B. So those patients achieved faster marker repigmentation. So only disadvantage, it may cause hyperpigmentation of normal skin. And they have also done certain pilot study on this gliadin protected superoxide dismutase. So we have this topical superoxide dismutase cream, whereas here they have tried oral superoxide dismutase. Since it is easily digested in the stomach, to overcome that, they have added the gliadin polymer to enhance its systemic absorption. So they have tried in few patients wherein they have given 500 milligram BD for 3 months, followed by 500 milligram OD for 3 months. So those patients have achieved marker repigmentation at the end of 6 months. This has been reported in European Academy of Dermatology. And the latest one under pipeline is the monoclonal antibody against interleukin-15 receptor. Because interleukin-15, as you all know, it's essential for the survival of the CD8 memory T cells in the skin. It is that memory T cells in the skin that is always responsible for the relapse after completion of the treatment. So when we target this molecule, particular monoclonal antibodies, that will remove the target memory cells so that the relapse can be prevented. So this is again at the pipeline. And some of the other newer emerging treatment include this WNT agonist. So this pathway is important for the melanocyte migration, proliferation, and differentiation. So again, it is under pipeline. And the newer addition to this emerging treatment includes the gain switch titanium sapphire laser. It's more or less similar to that Excimer laser we have. The wavelength is 311 nanometer. So similar to Excimer laser, it is given twice a week for 3 to 4 months, particularly in localized vitiligo. The advantage is it penetrates deeper compared to this Excimer, and no need for gas recharge, unlike this, because it's a solid medium laser, unlike this Excimer where we have to recharge the xenon gas. And again, that results are encouraging one. And this has been reported in JAMA Dermatologist 2017. So coming to the diet and antioxidants. So in general, we always advise this diet with vitamin C rich products or so diet we have to avoid. But there is no data supporting this claim. But we have to advise the patient to avoid this vegetable oil rich in omega-6, which may increase the production of that deactivated oxygen species and pro-inflammatory cytokines. And those vitiligo patients who are associated celiac disease should avoid the gluten diet. So what is the rationale for giving antioxidants? So in vitiligo, one of the pathogenesis is that increased melanocyte stress due to the reduced redox potential of the melanocyte. So the free radicals will damage that lipid membrane of the melanocyte, causing lipid peroxidation and causing apoptosis. And that will also leading on to the generation of that patterns and which may induce the innate and adaptive immune response. So antioxidants in general are always used adjuvant treatment, preferably when we put the patient for phototherapy, either before or and also during treatment. And can be also used as a maintenance treatment. Some of the promising antioxidants include the ginkgo biloba, which will be given in a dose of 60 to 120 milligram BD, and polypodium leucotomus should be given in a dose of 240 milligram BD. In general, we have to use a pool of antioxidants, not a particular antioxidant. So that will have very good effect rather than a single antioxidant. Some of the vitamins that have been prescribed in vitiligo include this vitamin B12, vitamin C, vitamin D. Of course, I always prescribe vitamin D, and vitamin E, zinc, and so on. And one more molecule, that minocycline is an excellent antioxidant. They have also tried minocycline in the treatment of vitiligo. So combination treatment. So what is the rationale behind combination of treatment? So no particular treatment is completely effective in vitiligo. So we have to combine various molecules which will have much more promising effect on this pathogenesis of that melanocyte, because these act at various causes, not only addressing the autoimmunity but also antioxidant, and they also stimulate the melanocyte reservoir, synergistic effect, and the response is quicker and maximum repigmentation, less side effects. So when we come in phototherapy with some of the other molecules, we can reduce the cumulative dose of that phototherapy, always tried in resistant vitiligo. So some of the combinations include steroid combinations include TCS with vitamin D3 analogs, has been found to be effective in vitiligo over the face, particularly in children. And similarly, a topical corticosteroid, narrowband ultraviolet B therapy. So for resistant lesions over the bony prominence, they have tried. And cyclical treatment, TCA for 2 weeks, that is tacrolimus for 2 weeks, followed by TCS for 4 weeks. And prostaglandin analogs has been combined with topical corticosteroid. And some of that interesting combinations they have tried include this topical corticosteroid, tretinoin, topical corticosteroid, Coltar. And of course, following Punchcraft also, we can use this topical corticosteroid. Coming to the combination treatment with topical calcineurin inhibitors. So combination of topical calcineurin inhibitors is targeted narrowband ultraviolet B or narrowband ultraviolet B with systemic corticosteroid, recent onset segmental vitiligo, that has been found to give very good results. And the topical calcineurin inhibitor has been combined with the ultraviolet B therapy. And cyclical treatment, topical corticosteroids can be done, as I said earlier. And similarly, the fibroblast growth factor decapeptyl can be combined with the topical calcineurin inhibitor, and prostaglandin 2 alpha analog also can be combined with topical calcineurin inhibitors. Coming to the phototherapy combination, so topical steroids with narrowband ultraviolet B therapy with this Excimer laser. So particularly for the bony lesions, and that decreases the cumulative dose of phototherapy. And topical calcineurin inhibitor, again, combination with the narrowband ultraviolet B therapy. But we have to look for that because we don't have any data on that carcinogenesis when we use this combination. And vitamin D analog with phototherapy, in general, it's not at all effective one. So they don't recommend this thing. And antioxidant can be given before and during phototherapy. And phototherapy can be done following surgery. So some of the other combinations where we have limited data include this topical pseudocatalyst with ultraviolet radiation therapy and afamelanotide with narrowband ultraviolet B therapy, CO2 laser dermabrasion with narrowband ultraviolet B therapy, ABM, this we have already seen. And the low-dose oral steroids post-surgery and low-dose azothioprine plus PUA therapy. Oral mini-pulse therapy can also be combined with phototherapy, and Soralan can be combined with the narrowband ultraviolet B therapy. So depigmentation, so in main indication is widespread vitiligo, more than 50% of the body surface and refractive vitiligo. So mostly it is done for type 5 and 6 skin. They are the ideal candidates. So we have a lot of molecules. The most commonly used one is this monobenzyl ether of hydroquinone. So it is all depigmented areas are not treated at once. You have to select, give priority to certain areas of the face, neck, and then trunk. So start with low concentration of the face, and then you can move on to that neck, and then legs and arms. Then we can increase the concentration. Applied uniformly 2 to 3 times daily. Remember that depigmentation is a slow one. It may take at least 4 months for maximum effect to be seen. If no or inadequate response even after 4 months, then we have to stop the treatment. Always advise the patient to avoid sunlight because that may prevent repigmentation. And maintenance treatment to be done to prevent relapse at least twice a week. Side effect is only irritant contact dermatitis, very common. Sometimes allergic contact dermatitis, and remote areas may be depigmented as a result of this application, and conjugal depigmentation. So partner skin may be depigmented, that we have to advise. And unmasking of telangiectasia and phlebectasia on the depigmented skin. Some of the other options for depigmentation include the cryotherapy, but there is always chance for scarring, and Q6 ruby laser and Q6 Alexander laser. The one advantage with this laser depigmentation is that action is very fast. Unlike this one, monobenzyl ether of hydroquinone, it takes at least 4 months, whereas with laser, there is a depigmentation effect seen within 1 to 2 weeks. So camouflage. So this during social gathering, they have to camouflage that area. So which includes temporary, semi-permanent, permanent method. So temporary method includes self-tanning agents. So the tanning, it gives a natural tan-like color, and usually lasts for 3 to 5 days, and waterproof and does not stain the cloth. And highly pigmented cover creams, they are lightweighted, waterproof, fragrance-free, but they have to be removed every day by makeup remover. Permanent camouflage include this micropigmentation tattoos, particularly for lip vitiligo and areolar vitiligo. So to conclude, so medical treatment is effective only in 60 to 70% of the patient. So TCI, tacrolimus, is effective in head and neck vitiligo, and TCS is the first line of treatment, topical corticosteroid and extrafacial limited vitiligo. And oral mini-pulse steroids and immunosuppressives are useful in halting the progression of rapidly progressive vitiligo. So phototherapy is the first line of treatment in generalized vitiligo. Mostly we prefer narrowband ultraviolet B over PUA. And Janus kinase inhibitor is a promising treatment, and particularly this topical ruxolitinib cream has given very good repigmentation at the end of 3 to 6 months. And so various combination of treatment will address the different pathogenesis and giving the synergistic effect. That will be a much more effective one rather than trying sticking on to that single treatment. And depigmentation is approved for vitiligo involving more than 50% of the area. So these are the references. Thank you for the patient listening.
Thank you so much, sir. You had covered entirely everything that one would need to know when they are handling vitiligo. The medical management completely done. Thank you so much for that exhaustive presentation, sir. Next, we will have Dr. Mohana Sundari talking on Excimer and its role in vitiligo.
Madam, is it visible, madam?
Yes.
GV, make it full screen. Yes, GV is visible.
Dr. Mohana Sundari, you can start, ma'am. Ajinkya, she's online, right?
Yes, ma'am. Madam is
Please
online.
unmute, madam. Please unmute and talk, madam.
We can't see her.
She's switched on her camera also.
And the left side bottom.
Yeah, she's there. Hello. Yeah, she's there.
You should switch on both audio and video.
Madam, we are not able to hear you.
I think she again logged out and she logged in.
Mohana Sundari, madam, you're online. We are not able to hear you.
She is logged in without voice. Ma'am, you have to re-log in.
Madam, madam is asking to continue with the Ravi sir first, and then she will do it later.
Okay. Then you can stop sharing the screen.
Yeah, then GV
Sir,
said
we'll
stop
have
sharing.
your presentation, sir.
Dr. Mohana.
So since we have some difficulty with Dr. Mohana Sundari logging in, we will move with the next talk. We have with us none other than Dr. Ravichandran, sir. So we will have recent advances, interventions, surgical methods, tackling vitiligo at best from sir himself.
Thank you for your kind words of introduction. Yes, and thank you so much for your kind invitation from the IADVL Tamil Nadu branch, and Dr. Annie particularly, and Kalishwaran sir. Thank you, Kalishwaran, for your kind words of introduction, which taking back our memories. It's very important for all of us, no? Vitiligo, I think Vijay Anand did a wonderful job on giving you the topic. But my topic will be on recent advances, interventions, and surgical methods, tackling vitiligo at best. You all know that this is the most important, difficult topic, difficult disease for the patient as well as for the treating doctor, consultant dermatologist. And every day, every new things are developing. And when Vijay Anand was telling about listing all the new things, but what best we can use, what are the available current methods, and what will be the future options. I will quickly go through my set of slides today, and hope it's going to be a little more take-home message today. It's a wide spectrum. The melanocyte, which is a unicellular cell, which causes the cells to produce melanin, is yes. You see the patches here everywhere. It's across the body, mucous membrane, genital mucosa, hair
So slide is not moving, sir. We are just seeing the first slide and it is not in slideshow view, sir.
1 minute. Sorry.
So, sir, can you click on the bottom slideshow icon near that percentage?
Yes, yes.
Yeah.
Yes. So small hitch anyway. Thank you for kind invitation. And this will be my topic today on recent trends, interventions, and surgical methods. And probably the postgraduate young bright dermatologist will be able to get to their, this topic very well. As you all know that depigmentation starts everywhere across the skin surface, the hair follicles, the mucous membrane, the genital oral, as well as across any places in the body, including the eye and other areas. We have the non-segmental and segmental, which Dr. Vijay Anand was telling about the different types of vitiligo. And I just think some very difficult condition to manage. And then the hair follicle, the chemical leukoderma, the acral one. My God, it's mind-boggling. No, every day new presentations do occur. And of course, I am not doing something on the childhood vitiligo today. It is one of the most important condition, treating the child with vitiligo. Not only the child, the whole family we need to treat and counsel them to take good results. Vijay Anand was telling me about this topic of immune pathogenesis of vitiligo. Now it's been very clear that JAK pathway with the receptor, the gamma interferon activation, as well as the role of all the cytokines. This is one area which recently has developed, probably giving a path to the further evolution of biologics and other immune-mediated targeted therapeutic molecules coming in the future. I will also go through that topic at the end of the day. Okay, clearly done that. All of us know that topical, oral, phototherapy, surgical, but today JAK is emerging in a fast way, in a big way. The JAK inhibitors play a major role in this immune pathway. And whether we are going to give oral or topical, we do not know. We will have to wait and see. It's a recent event, but one has to really carefully monitor the side effects of JAK and absolute indications and pre-workup before you start, particularly in India. It is something like a biologic. We need to look at the viral hepatitis markers, then the tuberculosis infection, tuberculosis there, and of course the lipid profiles and the vascular complications and reactivation of the herpes zoster, which we have seen quite a number of patients on oral JAK inhibitors like tofacitinib. Biologics are yet to come to in the treatment of vitiligo. And of course, there are a lot of molecules which probably in the 2023 or 24, we should be having for generalized non-segmental vitiligo. Of course, some of my speaker will be talking about on Excimer laser. And I am going to talk to you today much on the tissue grafts and the cellular grafts. So when you see a patient with vitiligo, how do you look at it? And what are the interventions you can play? See, first and foremost is the prevent the precipitating factors. Trauma. I learned this from Falabella and from Professor P.N. Bell, that Ben will always say that whenever the child particularly do not use the strong towels or rub everything, no trauma to be there, no mosquito bites, no chemical toxicity. So much of Kubner phenomenon can induce vitiligo, thereby putting the melanocytes into the immune system. Start antioxidant. A very good slide, which I was very clear in seeing Dr. Vijay. The role of antioxidants is very important in the early stages of vitiligo. Then we focus on how do you treat the immune-mediated attack on melanocytes. We have the corticosteroids, both topical and systemic, the calcineurin inhibitors, the topical tacrolimus and pimicrolimus. Of course, JAK inhibitors are in the market, and I have given for a few patients, but it has to be very clear. It is not those oral JAK inhibitors are not been approved by the FDA, though it's been used in the rheumatological conditions, and one has to, we doctors have started using it. And when and where and how, what about the further improvements and all, we need to look at this at the subsequent months and years to come. How do you increase the melanocyte and melanocytes? By phototherapy and FMLT9. So this will be a new topic. Phototherapy is time immemorial. We have been having both narrowband UVB and UVA and targeted and Excimer lasers. They play a major role in particularly during active disease as well as in post-procedure. One important thing I just wanted to highlight that phototherapy, if it forms as a Kubner-ized phenomenon, please do not initiate phototherapy when it aggravates the condition. So one important guideline that I have seen quite a number of patients worsening with phototherapy. Please look carefully at these patients that they should not have a photokubnerization. Of course, the favorite procedure which I do is surgical methods. I will quickly go through all the set of slides, including the video clippings. Okay, what are the current surgical methods are available? Our Association of Cutaneous Surgeons of India has done an excellent job in taking this topic across India, across not only Indian borders, across the world. So I think this has become very popular in India, that tissue grafts, cellular grafts play a major role in stable vitiligo, refractory vitiligo. And what are the tissue grafts? We have the thin, ultra-thin skin grafts, suction blister grafts, mini punch grafts, and hair follicle grafts. I started with the small mini punch grafts those days from Dr. Bell's Institute. And now we always know that we have been doing the excellent procedures of the NCES, the cellular one, non-cultured epidermal cell suspension, cultured pure melanocytes, cultured epithelial grafts, and autologous non-cultured extracted hair follicle outer root sheath cell suspension. This is one topic. The last one is just emerging as a research tool, that how best we can do the culture of this outer root sheath cells which contains the melanocyte. This is just a small overview about if any of the young dermatologists, postgraduates, or professors want to give a dissertation for this topic. I'll be very happy to share my experience. Before we start doing a surgical procedure, we must understand the basic pathology of the vitiligo. Vitiligo involves a chronic loss of melanocytes in the area of depigmentation. This is a normal skin. And vitiligo macules could pass through two stages. The first stage is the reversible loss with partial melanocyte loss. This is what happens, you see. And there are few melanocytes. There we can stimulate it. And the second stage involves irreversible with total melanocytes loss. Absolutely, there are no melanocytes. We need to be very careful about transferring the live melanocytes, autologous melanocytes from the donor area to these areas. And depending upon the site and the extent, we plan how to proceed with this graft, which I will be giving you few slides. The origin and the journey of vitiligo surgery. Of course, I was one of the respects to my Professor P.N. Bell and Professor Patrick Kesudayan of doing this topic across all these years. And concept of surgical treatment of vitiligo was first proposed by a few pioneers like P.N. Bell and of course from US Palabella. Over the years, it has been expanded to include surgical biotherapies like autologous cultured melanocytes. So we began with small punch grafts. Now we have taken this and NCS procedures as well as just starting melanocytes across in the recent times. How do you choose your patients? Before a surgical treatment is planned, several points should be considered and discussed with the patient. The patient should be clearly informed about the nature of the procedure, expected outcome, and possible side effects. The choice of surgical intervention should be individualized as vitiligo type, stability, sites involved, localization of the lesions, and cost effectiveness of the procedure. Please have a good, frank discussion and identification sites involved, and stability has to be assessed before you start putting your knife there. How do you assess the stability? There are a lot of talk about this topic, but now the recommended period from our IADVL Association of Cutaneous Surgeons Association is less than 1 year, and it can be also extended to up to 2 years. Vitiligo can be classified as stable when progression of old lesions and development of no new lesions occur in the past 1 year. How do you assess stability? One is the distal progression, the extension of the old lesions, Kubner phenomenon, and mini graft testing or minicellular grafts. Of course, Professor Somesh Gupta and Devinder Prasad always says that there can be a regional stability, but overall stability may not be there. So we need to identify the patches which have got a recent stability so that you can cover these areas of vitiligo and the sun exposed as a quick procedure. This is a very interesting stable vitiligo, which we all started. Young postgraduates can try this. This over-under punch, I got it long back. Nowadays, disposable punches are available, and you just give a local anesthesia, infiltration anesthesia, take a mini grafting called 1.5 or 1 millimeter. Of course, there are 4 millimeter, 3 millimeters. You just implant it according to that. There's a migration of pigments, and you can combine with phototherapy. It's a very easy procedure. At one go, probably this will take an hour or so to complete it, and phototherapy and excellent repigmentation. Of course, we need to be very careful. You've got to choose a stable vitiligo with a little hyperpigmented border with phototherapy. You can always see, but never you can do a kind of loss because it's called the reverse Kubner. Never do it for an unstable active vitiligo. This was the result which you can get. Of course, nipple areola punch grafting is an ideal for a woman, and this is just how we proceed. Epidermal skin grafting is also very useful, like an do the dermabrasion part and do an ultra thin. 7 days later, you get a nice smooth pigmentation. This advantages of an epidermal graft and ultra thin graft is that you get a more or less like a melanocyte cell transplantation. It can be done in stages. It is suited for focal vitiligo, segmental vitiligo, or vitiligo which is a little refractory. Large areas can be taken up, particularly the face lesions. This gentleman was worried about that. He did extremely well after stabilizing the disease. I could do this result. So easy, so simple, but time consuming. We have equipments are available. You can take the two-way syringe and then raise blisters and take open the blisters, do a dermabrasion, and then put a small graft here like these. All the pigmentation. Maybe it's a little blotchy, but you can always get a very good results for the blister roof grafts of the lips. So dermabrasion is very important to be done. You can take a small graft in multiple grafts and good excellent results. This is the in thing now across the world, across India, and I think most of the departments of medical colleges have started doing that. I was very happy to put this program in most of the medical colleges in Tamil Nadu. IADVL is proud to do this as a venture, and the non-cultured epidermal cell substitution is an important topic. And of course, if you are an advanced center, if you are trained yourself very, very well, you can proceed to do a culture melanocytes which gives an excellent results. Of course, we need to have an ethical committee clearance as well as equipments needed. I will just go through the set of slides. Okay, what are the cellular grafts techniques involved? It's how do you proceed to do this? You have to have some equipments and the tissue culture reagents of trypsin EDTA 0.25% solution. This is the one. And we have the trypsin inhibitor. This is the one. And Dolby-Co's modified ECOS medium from Sigma Ultrich lab, which is stored in the fridge. These two things to be stored in the freezer compartment. This can be stored in the ordinary tray 4 degrees centigrade, so that this has to be cold storage, have to be maintained very carefully to the viability, so that the response should be very, very good. Of course, small equipments are available. You have dental micromotor, we have an incubator, we have the surgical tray and dressing materials, of course, petri dishes to use that, and centrifuge if necessary. I started using the centrifuge. Nowadays, I don't use it. Centrifuge. It's a very modified techniques are available. We can do a small procedure within 30 minutes, less than an hour for an extensive areas. This is called modified Olsen-Jolien technique. 3-step procedure: harvesting the donor skin, laboratory preparation of melanocyte-rich cell suspension, dermabrasion followed by application of suspension over the dermabrated depigmented recipient. Very easy, very simple. Quickly, you can go through this set of slides. How do you do? You can do it under topical anesthesia, local infiltration, xylocaine infiltration, or under IV sedation. If a child is there, please ask your anesthetist to sedate the child. Topical EMLA application over the donor and recipient sites for 90 minutes to 120 minutes. Very important. We have to have at least minimum 2 hours to have such a pain-free procedure. Ultra thin and epidermal can be taken from the donor side using a shaving blade or a Humphrey's knife, and it's you can also take small punches and then float this one. If you are not very comfortable in taking epidermal graft, you can do 4 millimeter punches around half a dozen or 10, and then take off that epidermal the fat layer and then incubate it. Skin graft to be incubated in trypsin EDTA solution for 30 minutes to 90 minutes, and the melanocyte keratinocyte cell suspension separated in the tissue culture medium and aspirated in a 1 ml syringe. The cells are spread over the dermabrasion vitiligo patches, which can be done by a dermabrasion unit with the diamond phrases, micromotor, or if you have a carbon dioxide regular laser, you can do a carbon dioxide resurfacing, and we can also do that. There are a lot of techniques are available. Modifications are self-centered, and it's transparent with the transparent collagen sheet. Dressing is done, and we need to remove the dressing after the 7th day from the donor and the recipient side. Generally, secondary infections do not occur, and patients also lip vitiligo, of course, is the most important site. Always I do use even if you do a small melanocyte cell suspension or an ultra thin graft on the lip vitiligo, I always use a transparent collagen as a good dressing so that it clicks and seals that area. The graft doesn't slide away when the patient takes food. This is after say 30-40 minutes, so you see the epidermis cells separated. You take it in a small syringe there, fully loaded, and do a dermabrasion and dribble this and put this transparent collagen sheet. This is a very easy method of doing it, and of course you can train your paramedic staff nurses in the theater. It can be done in a small sterile procedure room. You really do not need to go a full operation theater, surgical theater, but this is how it is done. I'll just quickly go through a set of slides. You can take the epidermal graft in many methods. This simple harvesting technique of a donor area. I always use the right gluteal upper outer quadrants. Never do it on the front of thighs or inner aspect of the arms, because this can cause scarring. You see such a thin graft coming out. So this is a very important agent, because for an epidermal graft, as you can see, it is a very simple procedure. So please watch carefully and train this particularly with the take of a small blade and handpiece, straight handpiece, and then try to peel the onion skin or a tomato skin and try to get to know that. And even if it's full thickness, doesn't matter. Maybe you need to incubate it a little longer time. Probably this will require less than 30 minutes, 15 to 30 minutes to take the digestion by the trypsin. Simply, you can use hand dermabrader or a diamond phrases. So you can always, this old video, sorry, braided till a uniform pin per body. We have dental burrs are available in different shapes, dental straight handpiece with a dental motor available. It's very cost-effective procedure. You can do a ETO sterilization, autoclave it, and so that you get a good results. Superficial, never go deep, because if you scar the area, there may not be a good effect of this procedure. So that's a good area of dermabrasion. And you can keep using it. Maybe if you use a small new burr, probably the abrasion is faster. You got to put a little more pressure on the skin. Topically, it doesn't have any pain because occlusion is around 2 hours. Infiltration anesthesia also you can use with large area. The pain is not there for these people. Yeah, the cells, the skin grafting is taken away and then put it in a small petri dish. And then we have Joller's forceps to tease out the cells. The dermis is separated, the epidermal melanocytes, you can see the brown pigmented melanocytes, keratinocytes, particularly never leave the basal layer. Try to take the basal cells, very important that basal melanocytes are there. There you can see the whitish skin there, and the melanocytes are adhered to this so that you can separate this melanocytes, keratinocytes, and the basal melanocytes. Very important. Of course, the epidermis also contain a melanin ghrelin keratinocyte. So this is a suspension of melanocytes cells, keratinocytes and melanocytes. So this is this is the leftover skin, and you can see here the 1 ml of almost you can cut 10 times. So if you're going to take 1 ml of this, you can do a 10 ml of 10 centimeter of the pressure areas involved. So you just dermabrate it and then separate transfer the cells all over the area and keep ready your transparent collagen. And you can just very easy and very nice. Once you see the cell suspension, it's really impressive, and very happy that we can easily even predict the result on the table itself. So this is how we separate the cells, do a small collagen dressing, and of course we can always use a bactigras and the collagen. I used to do not want to waste all this cell suspension, but you can't use more than required amount. Sometimes we do see post hyperpigmentation of these areas. If it's a covered area, it's well and good. If we are going to do a face area like this, it can cause hyperpigmentation, though the texture, quality, smoothness, everything is there. But please do not add more of the cells you don't want it to waste. Don't pour it onto the dermabrated areas. This is a simple, along with your melanocyte, keratinocytes, epidermis cells, you can also do with a 1 millimeter, 0.8 millimeter motorist or regular punches. Take your punches around, float it in a petri dish containing normal saline, and then incubate it, and then you have the same method by which hair follicle melanocyte, because hair follicle melanocytes have got stem cells. So you see here small pellet of hair follicle melanocytes and the skin melanocytes. I always combine both these together so that we achieve better results at the end of the day. So this is very useful technique. If you do not want to scar the skin of the lateral thigh or the gluteal surface, particularly in women and girls, always go for the hair follicle. So this is quite sufficient to do the small patches of segmental vitiligo. Coming to the topic of melanocyte culture, which is new happening, which recently planning to start, almost everything is ready. The why, how, and future. So advantages and setup is required. How can be done? It's very easy technique, only then time consuming. And what will be the future implications of this procedure? Why melanocyte culture? Because large areas can be tackled well, less donor tissue, because you take a 4 millimeter punch, that's sufficient to develop into a cell line, and in a matter of say 2 months, 2 weeks, we get around 2 lakh cells of the melanocytes and keratinocytes. It's a cryopreserved, can be preserved, excellent cosmetic results. The only thing the patient have to come up for 2 sessions. The first treatment will be taking the skin in the form of a punch graft, or using a melanocyte pellet also can be given. The cell suspension also can be inoculated into the cultured medium. We have a good cultured mediums are available. we need to require centrifuge, laminar flow, inverter microscope, incubator, reagents, and operation theater. It takes around 2 weeks for the cells to be, you need a small biotechnologist to see whether the cells are being developing, multiplying by using the petri dish in the inverter microscope. Same procedure, take the media cell suspension, buy the melanocyte culture medium, and then suspend the cell pellet in 5 ml of the medium, inoculate in T25 culture flask, incubate it at 37 degrees for 3 weeks, separate the melanocyte using the trypsin EDTA, incubate it again in the medium, keep it again, and this is going to be a process of 2 to 3 weeks, centrifuge at 6000 RPM for 6 minutes, resuspend the pellet in medium, check viability of the cells of the melanocytes by the counter, count 1000 to 1500 cells per square millimeter. It's an excellent one. As I told you, in 2 weeks, you get around 2 lakh cells of the keratinocytes and melanocytes. And this is which I went through this because I wanted to see this in old literature with Julien and been done on also. Long-term follow-up of leukoderma patients treated with transplant autologous cultured melanocytes. My God. So those days people have started as a research even, but this is going to be the future across the world and particularly India. So a few centers have started. I will be, once I start this procedure, I will let you know so that we can all start as a new venture for treatment of vitiligo. Results are excellent repigmentation with uniform color match and texture quality, most suitable for stable vitiligo and focal vitiligo. Results are, of course, I always credit my Professor Yesudi as patient, and he's done extremely well in 3 months' time. Even the hair follicles have started getting retrograde migration of pigment, very smooth, uniform. The halo can be treated well at a later date with the Excimer laser or topical, or even you can do a reprocedure mini micrografting. There's another segmental vitiligo from the age of 15 to she came to me when she was 25-year-old from treatment failure. So that I did this in 2 months results. We do get small islands left over do occur, but this can be transplanted again, or the post procedure in the form of a topical tacrolimus as well as the phototherapy Excimer laser can be tried, and of course this we achieve very good result. It takes 6 months to 1 year to get a good. See, advantages of this is the uniform color matching, texture quality, and smooth spread of this vitiligo. Complications do occur, perigraft halo, islands of vitiligo macules I showed in the picture. We need to follow with narrowband UV, Excimer or targeted. The procedure may be done in cases. Coming to the topic which was given to me as a recent advances, of course, this Opzelura, ruxolitinib, been approved for 1.5% in the treatment of facial vitiligo, non-segmental vitiligo by the FDA in the recent past, probably July 18th, 2022 has been approved in the adult and pediatric patients of 12 years of age and older. Inside is the guy company which made this ruxolitinib. They announced the approval in a big way in the world in the vitiligo treatment. Of course, results are very good, and it's a very expensive cream. The 15 grams costs around 80,000 rupees, our Indian currency. How far when we are going to get into this in the short, probably within this year, we should get ruxolitinib topical 1.5 cream in India. Of course, Jack was talked, and then we have no answer for this, but it acts in a big way in the interferon gamma, and how far this is going to play a role in the future. And I see a lot of prescription unfolded into this treatment of vitiligo across the other countries too. But one has to be very, very careful. I was just telling you, please choose your candidate, screen them individually for hepatitis markers, tuberculosis, and then reactivation, start giving a herpes zoster vaccine before you start these patients with JAK, tofacitinib for psoriasis, vitiligo, alopecia areata. I have seen excellent work in alopecia totalis. Of course, psoriasis I have not much experience. In vitiligo I have given for active vitiligo in certain cases, and we need to wait. So be careful. So don't jump to start tofacitinib in all the patients, which is going to happen shortly. Be careful. And yeah, this is of course the microneedling and topical 5FU with an Excimer laser. I think this is a new thing which is in the research publications from the phase 3 trial, which is coming up in the research area. And in the postgraduate institutes can definitely try these things and look at the resistant vitiligo. Of course, cytokines, the biologics are going to be in the pipeline, and we'll wait for that. And thank you so much. Vitiligo patients are just differently colored. Let us add color to their life. And I always thank bow my head to Professor Patrick Yasudayan, Professor P.N. Bell, Professor Jani Madam, my teachers and colleagues and patients, of course, my colleagues across the medical colleges in Tamil Nadu for your kind invitation, all these years of training and doing procedures on vitiligo, demonstrating. And I always thank the IADVL, as Dr. Kalishwaran and Annie Flora said. This is the topic which belongs to a dermatologist, and we need to have improvement in this topic, and definitely we need to add colors to that life. Thank you so much. Thank you very much.
Thank you, sir, which was a wonderful presentation. We really enjoyed all your slides and the video, how you showed it in a very simplified manner. And it was very motivating. Hope all the juniors took the message that it's high time that everyone starts practicing this. And thank you really so much, sir, for the presentation. Next, we'll have Dr. Mohana Sundari. She's going to talk on Excimer laser for us.
GV sir, can you hear me?
Yes, sir, I'm able to hear.
Yeah. Okay. I thought this is a blank slide.
Okay, I'll share it. I'll share my screen, sir. I'll share my
No,
screen.
no, your screen is being visible.
No, it is actually Madam has shared that screen.
Okay, madam, I shared the screen. No problem. Then it's okay.
Madam, you're not. 1 second, madam. Madam, I will share my screen.
Mohana Sundari, ma'am, we are not able to hear you.
Madam, already you have shared the screen. No, that is the reason I'm unable to open it. Yes, madam. Just a second, madam. I'm sharing my screen. Voice is not coming, madam. That is the reason. Hello, madam. Can you just talk by unmuting?
No, she's not on mute, but we are not able to hear. Mohana Sundari, ma'am, can you just say something?
Madam, no, madam. Your voice is not audible.
Can you log in from your phone, ma'am, if your laptop is not allowing? The mic is not visible now.
Ajinkya, sir.
Is it
Tell
visible?
me, sir.
Sir, can you just talk to madam directly once? Because her audio is not there. Her audio is off.
Now she talked. I think we could hear. Mohana Sundari ma'am, can you say something? Yeah,
Yes,
now
ma'am.
we can hear.
Now visible. So
Okay.
GV sir, you can share the screen.
Just a second, sir. Just a second, sir. I'll mute.
Yes, sir. Okay. Hello.
Yes, ma'am, you are audible.
Am I audible now?
Yes, yes.
First slide, please. Sorry. So thanks to thanks to IADVL TN for giving me this opportunity. Thanks to our IADVL Secretary, Dr. Andy, and IADVL President. So I'm going to talk on Excimer laser in vitiligo. So moving on to, so we have listened to the exhaustive lectures by Professor Ravichandran and Professor Vijay Anand, sir. So it has been, as you all know, that vitiligo is a disorder of depigmentation, occurred disorder of depigmentation due to destruction of melanocytes, leading. So various theories has been put forward that has been explained in detail by Vijay Anand, sir. So it leads to a lot of psychosocial morbidity. So the objective of the treatment of vitiligo is the stabilization of the depigmented lesion and to stimulate repigmentation. So besides this medical therapy and surgical therapy, light therapy is also going to play a vital role in vitiligo. That includes photochemotherapy or PUVA, narrowband UV, and the newer targeted phototherapy devices that includes Excimer laser and Excimer lamp. Both are approved by US FDA for the treatment of vitiligo. So for medical purposes, the lasers, Excimer lasers available so far are 193 nanometer organ fluoride laser, 248 nanometer krypton fluoride laser, 351 nanometer xenon fluoride laser, and 308 nanometer xenon chloride laser that is being used in dermatology widely nowadays. So what do you mean by the term Excimer? The term Excimer is a short form of excited dimer. That means it's a molecule formed by combining two identical noble gas, argon, krypton, xenon atoms in an excited state. This Excimer laser uses noble gases and halides, either chlorine or fluorine, and this combination is called exciplex or in an excited complex state. So, and this combination exists in the excited state, and this in this excited state, it leaves energy. So this is a picture of laser physics in Excimer laser. So moving on to Excimer lasers. So this is, as I told, this is a 308 nanometer range targeted phototherapy device. This has been first described in 1997 itself for the treatment of psoriasis. So here this excited dimer or Excimer is created and the laser light in the UV range. It works on the principle of ablative decomposition. The target chromophore here is DNA and proteins. It elicits a photochemical reaction. So it elicits this Excimer lamp or light. Excimer laser emits a coherent and monochromatic light at 308 nanometer range. How does it act in vitiligo? It inhibits the inflammation created by the cytotoxic T cell and induces T cell apoptosis and induces the differentiation of melanocyte stem cells and stimulates the production of melanin. So, and also the proliferation and migration of melanocytes inducing repigmentation. And also the main action is it stimulates the amelanotic melanocytes in the perifollicular region. By saying amelanotic melanocytes, it's a dopaminergic melanocytes also. So this is a Excimer lamp. So it has been discovered in the year 2003. It's here the light is incoherent, non-directional, monochromatic light. The instrument is a portable instrument and less costly comparing to laser, and it covers a larger field area, and it can be adjusted to the
size of the lesion. So it needs, but comparing to laser, it needs a longer time to deliver the shots, and you can cover a larger body surface area comparing to excimer laser. So how does this act? This also mainly concentrates on the inactive melanocytes present in the outer root sheath of the hair follicle. Mainly this inactive melanocytes present in the outer root sheath of the hair follicles are spared in most in vitiligo. So the initiation of therapy, the maturation in this latent melanocytes occurs, followed by migration upwards along the hair follicle with ultimate dissemination in the epidermis. This is a table showing the comparison of excimer laser and lamp. The wavelength here in laser is 308, whereas in lamp it is 304 and 308. The coherence is present in laser, where it is a non-coherent light in lamp, and the spot size is small in laser and it is larger in lamp, and erythema is less pronounced in laser and more pronounced in lamp. The treatment is, of course, it is costly with excimer laser and at a favorable cost in excimer lamp. So the indications for excimer lamp or light in dermatology includes, there are a wide list is available: vitiligo, psoriasis, atopic dermatitis, alopecia areata, allergic rhinitis, folliculitis, granuloma annulare, lichen planus, mycosis fungoides, palmoplantar pustulosis, pityriasis alba, CD30 lymphoproliferative disorders, leukodermas, both chemical and drug-induced leukodermas. There is an excellent result. Prurigo nodularis, localized scleroderma, and genital lichen sclerosis. So the indications for excimer lamp or light in vitiligo, when it is involving the body surface area, is less than 20%, and chemical leukodermas, both chemical leukodermas and drug-induced leukodermas can also be treated. And following 4 surgeries for vitiligo, we have listened to the surgery for vitiligo, both cellular vitiligo, cellular surgery and graft also will be benefited. And post-tattoo depigmentations and depigmented scars are also showing an excellent results, and striae alba can also be treated with eximers. So the contraindications include history of photosensitivity and photodermatosis like systemic lupus erythematosus, genophotodermatosis like xeroderma pigmentosum, and patients on photosensitizing drugs. And herpes simplex infection is a relative contraindication. It can be done under the cover of acyclovir prophylaxis, and Fitzpatrick skin type 1 and 2. So the procedure includes, you should get for all procedures, you should get an informed consent and photo documentation, pre and post procedures photo documentations, eye protections. The parameters for excimer include, for the head and neck area, it is 100 to 150 millijoules per centimeter square. For arms and trunk, it is 200 millijoules. For bony prominence, it is 300 millijoules. For palms and soles, it is 600 millijoules. So the increment for every session is 50 to 100 millijoules per treatment, and 2 to 3 times a week for a minimum period of 20 weeks. The response will be started seen from 4th week onwards. If there is no response in 20 weeks, it is called as treatment failure. So how to grade the clinical response with eximers? So we just termed as excellent when there is more than 75% of repigmentation, and good with 50% of repigmentation, and it is poor with less than 25% of repigmentation. So the complications include main is blistering, burning, hyperpigmentation, painful erythemas, erosions, and reactivation of herpes virus infections, skin aging, and increased risk of skin cancers. So how to manage? When there is a severe burns with excimer lamp, you decrease the joules by 50 millijoules or skip one session. And there is an when there is erythema, you decrease by 100 millijoules. If it is persistent beyond, even if you decrease 100 millijoules, you avoid on consecutive days and wait for the erythema to subside. If there is a blistering, we have to stop the treatment, treat the areas with the topical corticosteroids, and if needed, a short course of systemic steroids can also be tried. So the advantage here is with excimer lamp or light is, so healthy skin is not exposed to radiation, and different templates are used according to the area to be treated. High dose of radiation can be delivered with a reduced cumulative dose of irradiation, and the short course of treatment is effective. Areas difficult to reach with the conventional phototherapy, especially genitals and ears, can be safely treated, and it can be used safely in children. And the instrument is relatively a friendly instrument, and determination of MED is not needed here. So this is comparing with narrowband UV, spot or whole body narrowband UV. So the treatment here is short duration, low cumulative dosage, few long-term risks like the risk of actinic keratosis and long-term risk of non-melanoma skin cancers are not being reported with the Excimers, and it can be used in a high-risk populations, and increased complaints because of the patient-friendly instrument. And so Excimer lasers can be used with other combinations of the treatment which we have listened to Vijay sir and Ravichandran sir. It can be used alone, or it can be used with topical tacrolimus and Excimer laser. It can be used along with the topical calcipotriol or calcipotriene, and topical high potent topical steroids with Excimer lasers, and following vitiligo surgery for all surgeries, either cellular surgery or a graft surgery or any therapeutic wounding, everything you can follow it with Excimer laser. There is a good improvement. So sharing few photos of Excimer lasers before and after treatment. This is actually, this picture is taken from journal. There is an improvement. You can see the improvement in before and after treatment with Excimer lasers, and there is a good improvement in the around the perioral region also. And this is Excimer lamp with this picture. This man has been treated with the topical calcipotriene followed by Excimer laser, and you can see in the after picture there is more than 75% of repigmentation. And this is a combination with tacrolimus. And this picture shows the picture A is before starting Excimer laser treated with the tacrolimus, and the tacrolimus is combined after that along with Excimer laser. We can see more than 50% of the improvement repigmentation in the picture C. And this is for cellular graft. This patient has underwent cellular graft for depigmented patches over the left side of the face. We can see, and she was after cellular graft, she was started on Excimer laser from the second week onwards. We can see a marked improvement. Picture she is almost there is 100% improvement, and there is leukotrichia is also being we can see that the hair is also being pigmented. This is set another picture of cellular graft, and this also I want to highlight that here the eye is being eyelid lesions, and there is improvement in the leukotrichia also. And this patient had underwent suction blister graft, and there is mild perigraft halo and contractions and leukotrichia that is being treated with the Excimer laser, and there is an improvement in the perigraft halo. So these are the emerging lasers in vitiligo: fractional ablative lasers, helium neon lasers, titanium sapphire lasers, UV-A1 lasers, and for depigmentation therapy, Q6 nanosecond lasers. So from our department, we are having Excimer lamp, and I'm sharing just few photos from our experience. This patient has got a vitiligo vulgaris, stable disease, and she was subjected to Excimer lamp. This forehead lesion is treated only with Excimer light. This is after 1 month. We can see the improvement. This is at the end of 4th month, there is more than 50% repigmentation. And this patch is subjected for Jodhpur technique. Jodhpur technique is, as Ravi sir told, this is also a form of cellular graft. Instead of separating melanocytes from the this crushed material is spreaded in the recipient side. And this is pre-treatment Jodhpur technique. This is a picture. The patient is only followed up with the Jodhpur technique, only mild repigmentation. And even after 8 weeks, there is only mild repigmentation. And she was started on Excimer laser at the end of 12th week. And we can start, there is an improvement in the pigmentation. So at the end, this is at the end of the 5th month, and this is at the end of the 6 months. There is more than 60% of the pigmentation, and patient is very happy. So this, of course, a short presentation from IADVL task force. It can be you consult a qualified dermatologist for the treatment of vitiligo. Thank you very much for the opportunity given. Thank you.
Madam, can I go ahead with the second presentation, madam?
Yeah. Shall we move? Shall we move on to panel discussion? And
Yes, please.
sir?
We can.
மோகன் சுந்தரி மேம் நீங்க 2 இதுல லாகின் பண்ணிருக்கீங்க. அதனால எக்கோ ஆகுது. ஒன்னு வந்து மியூட் வச்சிருங்க. Can put one as mute. So we will move with the panel discussion now. I welcome Dr. Parthiban sir to join us. We have with us Dr. Ravichandran, Dr. Vijay Anand sir as panelists, and Dr. Mohana Sundari will be moderating the session.
Can you share the presentation? And GV, can you share the presentation now? Hello?
Madam, you will have to log out of one device, madam. The device in which you are hearing the audio, let it stay there. The other one, maybe you can log out.
Okay. Is it visible now?
Yes.
Okay. So it starts with Professor Ravichandran, sir.
Yes, please.
Please.
You can even ask questions. No need to have a slides.
Okay. Sir,
Yeah, what is the reason for graft rejection? That's the question you have.
yes, what is so we have seen from the presentation, and we have practically also experienced that a lot of grafts are getting rejected, either the cellular graft or blister graft or split skin graft. What is the reason for that graft rejection, sir?
Yes, the technique what one has done is very important. Prior to that, the most important factor is an unstable vitiligo, where though the grafts remains after few months, there's no pigmentation. Initially the graft is placed well, but you don't get the repigmentation across either to a punch graft, as I told you in the first picture, that reverse Kubner, or it can be due to a phenomenon of immune mediated reaction. That's why we need to use with a little topical tacrolimus. Prepare the patient well. You might have to go a small dose of steroids. The only condition here is the graft rejection is mainly due to an autoimmune phenomenon, or it could be a faulty technique, or the patients may not keep the graft in place due to faulty dressings. And of course, this is the commonest immediately or post rejection. Suppose it can happen within a matter of few days after the surgery is removed. So we can always redo that. How to prevent graft rejection?
Yes, sir. We'll move on to Vijay. Next question to Vijay, sir. We'll go in turn, sir.
Okay.
So Vijay, sir. Next slide, please. So Vijay, sir. So you will comment your view on stable vitiligo and how to assess the stability in vitiligos. Vijay, sir.
You are unmuted. You are unmute.
Am I audible now?
Yes, sir. Yes, sir.
Yeah, this was clearly explained by Dr. Ravichandran, sir.
Yes, sir.
And
Yes,
actually
sir.
the duration, yes, the duration was initially 2 years, then they reduced to 1 year. Now I think it is 6 months. There is no increase in the number of skin lesions, no enlargement of skin lesions. Of course, we have to use dermoscope, Kubner phenomenon. There are certain dermoscopic signs for activity of the disease, like this comet tail appearance, polka dot, starburst appearance, and all those things have to be looked for, and then that's how we have to assess the stability. Apart from that, clinical examination like enlargement, appearance of new lesions, and so on.
Yes, sir. And this recent guideline by IADVL task force says that on the journal article that we have a disease stability, lesional stability, and immunological stability, sir. So this disease stability for taking up procedures 6 months is enough, and to assess the stability, they said immunological stability can be done by assessing the cytotoxic T cells in the lesional skin. If it is very high, we should not subject the patient to either surgical cellular graft or non-cellular graft or any method of treatment, and we have to treat the patient with to stabilizing therapies as you highlighted, sir. And moving on to Dr. Parthiban, the first question to you is, and role of JAK inhibitors in vitiligo, both topical and systemic treatment, and it has been highlighted by both the professors, and it has been looking like a promising modality in nowadays now. Please comment your view on JAK inhibitors in vitiligo.
I thank Dr. Parishwaran, President, for this opportunity, and Secretary Member for Planning for the opportunity. I thank Dr. Sundari for asking this question, because this topical toxicity and systemic toxicity a little become the game changers for the treatment of vitiligo. Now that the pathogenesis
Audio is not.
Is it better now?
Is it audible? Am I audible now?
Yes, ma'am.
Yeah.
Parthiban, sir, we need the mic a little closer, sir.
Yes, ma'am. Now, is it audible now, ma'am?
Yes. Yes, sir.
Now, this topical tofacitinib becomes a little game changer, because we have seen a lot of cases in which tacrolimus has failed, where topical steroids cannot be faced for a long time, especially on the face for children. And topical tofacitinib is basically the JAK inhibitors work on the interferons. And as Dr. Vijay has rightly pointed out, the cytotoxic T cell, it has got the resident cell. That resident cell is making a persistent lesion. And if you want any drug to work on that, we need tofacitinib. And this tofacitinib will be, topical tofacitinib, I think it is a very good drug as long as the barrier function is all right, and as long as there is no herpes or any topical infection there. As far as this systemic role of tofacitinib can be used, provided the patient has got some other autoimmune disease which needs tofacitinib as a drug of choice. For example, they have an SLE or have a severe alopecia universalis along with vitiligo. I think then if there is no contraindication, there is no evidence of tuberculosis, or there is no evidence of herpes simplex or zoster, then we can go. But I think that before giving systemic tofacitinib, as Dr. Ravichandran told, we have to immunize the patient against herpes zoster vaccine. Because I think that because almost 100% of the patients who have been started on systemic tofacitinib have come with herpes zoster. Just like mycophenolic mofetil, the profound immunosuppression caused by this drug results in herpes zoster or simplex at any one point of time. So this drug, apart from tuberculosis to be ruled out in the systemic form, the other one which we keep in mind is this viruses. But we should also not forget that this JAK inhibitors are not only, though they block the interferons, we are losing a part of this immune surveillance, which means that long-term use of this JAK inhibitors, both systemic, can predispose to a malignancy, because we find that this JAK3 pathway, if it is congenitally absent, the patient has got subacute combined immunodeficiency, they may go in for, they have an early death, which means that the JAK inhibitors systemic cannot be given long term. We need some alternative at one point of time, like cyclosporine.
Okay. Moving on to Ravichandran, sir. So, how to prevent graft rejection, sir?
Yeah, the preparation is very important before you take up for any procedure, which I addressed that at the other time. You can move on to the third question. I'll address it.
So this, besides this technical fault, they say that the recent guidelines, before taking up the patient, 2 weeks of cyclosporine 100 milligram BD, followed by cyclosporine post-operatively, has a better effect in preventing the graft rejections. So
yes, it's a nice study trial done by Dr. Somesh Gupta from AIMS, and it's a very useful method by which we can always prevent the graft rejection. Mohana Sundari, madam, your audio is muted.
But if cyclosporine is contraindicated, 20 milligram of, am I audible now, sir?
Yes, yes.
20 milligram of systemic steroids or or depending on the body weight, 30 to 40 milligram of systemic steroids. Pre and post procedures prevents graft rejection, especially for cellular suspensions and
Yes,
taking up the. So that is one of the recent guidelines, sir.
yes, I understand. It's
Yes,
correct.
sir.
It's good.
Yes, sir. So moving on to Vijayanand, sir. The next question is. Next. Moving on to Vijayanand, sir.
Yes, sir. Yes, madam.
One second. See on vitiligo. So they have how to manage vitiligo in pregnancy and effect of vitiligo on pregnancy. Recently came across a lady appearing new vitiliginous patch during her first trimester itself. Very apprehensive. How to manage that case?
So there are certain drugs which are approved for use in pregnancy, but in general, I don't treat vitiligo during pregnancy. If at all you want to try, you can try this class 3 mid-potent steroid. That too after 20 weeks of pregnancy, because that time is very safe. But I though that narrowband ultraviolet B therapy can be tried, but it is safe not to use all these thing, because if anything untoward happens, they may attribute this incident to that laser, I mean therapy we prescribed during pregnancy. But guidelines recommend narrowband ultraviolet B, but always supplement with folic acid when we give phototherapy during pregnancy.
Okay. Tacrolimus, when will you advise? Is it safe in pregnancy?
No data, madam, but I don't use tacrolimus during pregnancy. But we can use, as I said, class 3 steroids after 20 weeks of pregnancy. They are safe because less systemic absorption and no atropogenic potential.
Okay. Ravi sir, would you like to add on? Any comment on vitiligo in pregnancy, sir?
Very unlikely if associated with other autoimmune comorbidity. We have to control that this aspect. Number two, topical so antioxidants also may play a role, but
Yes,
masterly inactivity definitely is very important, as Dr. Vijay Anand said. And
Yes,
weight,
sir.
because any disease worsens during pregnancy, and we need to reassure, do a counseling, and hold their hand. Probably we need to treat depending upon the type of vitiligo. If it's generalized vitiligo, hardly we can choose any systemic agents.
I think we should do a serum vitamin D and thyroid estimation, because vitiligo being an autoimmune disorder, it is better that we correct it. If it is an underlying pathology, we can correct it better.
Yeah, comorbidity.
Okay. Thank you. And moving on to Parthiban, on this role of prostaglandin analogs in vitiligo.
Exactly.
And it is being also an emerged as a promising modality now. Have you used and share your experience and your comment on
prostaglandin
that?
analogs have been, especially bimatoprost has been extremely has got good effect both in alopecia areata as well as in vitiligo, because this agent has got this prostaglandin E2 has got a powerful pro-mitogenic effect, and this is going to be this has got an effect both on the melanocyte as well as migration, and this will definitely have a good response in vitiligo. Incidentally, when this drug was used for glaucoma, it causes eyelash trichomegaly. That was the time when they tried to use it for alopecia areata also. So when you have a patient with, for example, the cases which you have periocular involvement, then I think that this drug will be a very good drug. And it has got no side effects at all, no contact dermatitis, no steroid-induced side effect, relatively less costly. Eye creams are available. Eye drops are available at a much less rate comparatively to the creams itself, because some of the cosmetic creams are little costly from some companies, but bimatoprost eye drops is available at a much lower rate.
Yeah, rightly said. As it has been pointed out, it is actually a serendipity, and first initially used for alopecia areata. Now it has been found that there is repigmentation of the hairs, especially in the eyelashes and eyebrows. So localized vitiligo involving the eyelashes and eyelids prostaglandin analog seems to be a promising modality where we cannot use potent steroids. So this seems to be a promising agent. Moving on to Ravichandran sir. So this is again a question on surgical method only, sir. How to enhance pigmentation following cellular graft? The picture. So most of the time we get 50% of the pigmentations or 60% of the pigmentations. So how to enhance this pigmentations?
The technique is most important here. The proper dermabrasion at the level of the dermoepidermal junction uniform is very important. Even when you do a cellular graft, some areas take up, some areas may not be taking up these areas because wrong technique, profit. That is why we always, sometimes because carbon dioxide laser uniform abrasion. That is one technical thing which we have to look. And then, of course, topical tacrolimus phototherapy, definitely POA as well as POSOL is very important if you have done a very good cellular grafts. Number 3, as you said, it can also be if you saw there may be delayed repigmentation. So in those situations, maybe a small trial of oral steroids or cyclosporine may help. The only thing is the technique is the most important way. Stability, you do a good technique, which I showed in some of these pictures, excellent repigmentation following cellular grafts can occur. Aided with antioxidants, topical tacrolimus, systemic steroid, topical steroids, Excimer laser will definitely increase the perigraft migration of the pigmentation.
Okay. So how long we have to wait for the pigmentation to appear following any surgical procedures?
A very good question. Yes, a very good question. This is one which is...
Patients are apprehensive. Immediately after removing the collagen sheet, they want the miracle to happen.
Yes,
so
this
is very difficult to...
Yeah, a very good question. Actually, this yesterday a patient came to me after 1 month of graft, hardly any pigmentation, is small tinge of brown pigmentation is there, but it is going to take at least minimum 2 to 3 months for the color to repigment to occur. The reassurance is very important, and once you see the pigmentation slowly builds up very, very well.
Okay, sir. Moving on to Vijay sir. So, comment on inflammatory vitiligo. Have you come across? For the benefit of postgraduates, a few points about
have surrounding rapidly spreading vitiligo. May have surrounding erythema. They respond better to the treatment. Steroids we can prescribe.
Yes, but they say that this inflammatory vitiligo, there is a surrounding erythema. It means that there is a cytotoxic T cells are more in that lesions, and there is a very high. The disease is very unstable, and even if there is a single patch, we have to start this patient on high dose steroids to stabilize the lesions, and with that also they have poor prognosis. Or we can move on to other agents like JAK inhibitors or even biologicals are being tried now. That is being question to the next question to Dr. Parthiban. So biologicals
regarding the question, Mohana Sundari, the inflammatory vitiligo, not only with erythema, you can have the border can be palpated. There will be small raised by edges. So that shows that T lymphocytes are impinging on the basal melanocytes areas.
Yes, sir. Yes, sir. Thank you, sir. Thanks for the points. And to question to Dr. Parthiban, so biologicals in unstable vitiligo.
This question of this biologicals in vitiligo itself is a big question, because most of the time usage of biologicals like anti-TNF agents have actually precipitated autoimmune disorders like vitiligo. They precipitate autoimmune disorders like SCLE, and they precipitate SLE. And apart from this JAK inhibitors, which the interferon pathway, we have got what is known as the immune checkpoint inhibitors and this PD-1, programmed death cell pathway, which are little ahead, little far beyond this pathway. When we use these checkpoint inhibitors and these PD-1 inhibitors, we get vitiligo. which means that vitiligo is not only a disease which is mediated by TNF, it is not only a disease which is mediated by interferon gamma, it is going to another spectrum of apoptosis pathway, which we have not explored at all, which means that usage of biologicals in unstable vitiligo, provided the patient has got another indication for the biological, we can use it. Otherwise, just for a unstable vitiligo, using a biological like anti-TNF may not be of much help, because in that particular patient, the interferon pathway must be genetically different, or the checkpoint inhibitor may be different, which will not be apparent to the clinician. So if you want to use a biological for a very severe, unstable vitiligo, I think that we should look at the pros and cons. But as per the standard books, there is no ultimate results of biologicals. And in here, there is one article which has been published which says that occurrence of more vitiliginous patches following the use of systemic biologicals. As I feel that if you're writing for a real case, there should be another indication for a biological. Let it alone be vitiligo. So I don't think biologicals are much useful for the unstable vitiligo, provided that we prove that it is only TNF which is working on the patient.
Yes, point is taken. As in the era of Google, and patients are coming with asking for these questions. So they already, especially at the referral centers, and they are treated with cyclosporine or mycophenolate mofetil as systemic steroids. They themselves Google out and they came with the question of biological. So that is why I asked, and it is being frequently asked by the this educated group. And IL-17, IL-23 blockers are being tried now.
They hope that IL-23 blockers have been focused, but I feel that is not alone the only pathway in which this one works, because the TH17 pathway is both shared by vitiligo as well as psoriasis, and it will also be shared by alopecia areata. This pathway is not going to be responsive to steroid, and this pathway has the role of tofacitinib as a main role. But in when you use tofacitinib, we always see that most of the time biologicals failure, tofacitinib helps. And I have seen that when biologicals are being used for psoriasis, patients have come with pustular psoriasis which responds to topical tofacitinib. So the blocking of TNF is not the ultimate aim in immune therapy. We have got interferons, we have got checkpoint mediators, we have got apoptosis for that. My point is that vitiligo is not a single disease of TNF alone. If that particular patient has got more of TNF, if it has been documented, then and if it is IL-23 is high, then we can choose for that particular patient. Probably we can do a cytokine analysis and then find out, check that TH17 pathway, but that is going to be a big long run.
Yes, Parthiban, actually there was a use of biologic. A trial was done on Alzheimer earlier in India from different centers. It was not found to be useful at all. If you remember Alzheimer.
Yes, sir. So, of course, so biologicals are not going to play a role in the management of vitiligo, as it already discussed. The small molecules like JAK inhibitors and apremilast are being tried here in vitiligo. So, moving on to
one point, madam.
Yes, sir.
Regarding this biological, one molecule is in pipeline addressing that blocking interleukin 15.
Yes,
because
sir.
this interleukin 15 is essential for the survivability of the CD8 memory T cells in the dermis.
Yes,
So if we attack that this interleukin 15 block using that interleukin 15 monoclonal antibody receptor blocker, and then this memory CD8 cytotoxic cells will be removed from the skin affected area, and then it will prevent the relapse of the lesion. That is in pipeline. Interleukin 15 receptor blocker.
But interleukin 15 is an agent which is used for antimicrobial defense system. So it is the major agent for all these defensins, beta defensins, and the other antimicrobial peptides, especially S100 protein. So even if that agent comes, I think we'll have to do some workup before we start that agent on. I agree completely with Dr. Vijay, sir, but I have this point in my view. I do not know how, unless this comes out, we do not really know.
Okay. Thank you, sir. Thanks for the point. And moving on to Ravichandran, sir. And before taking up a larger area for grafting, cellular grafting, do you do test grafts, sir?
Yes,
Is it a must? Is it a must? Do we need to explain?
Yes.
As we discussed, graft rejection, graft failure. So is it a must?
Yes. If there are no clinical evidence of repigmentation or stability, or we wanted to plan for a large areas of cellular grafts, I always do a small test punch graft. We take around 1 millimeter or 2 millimeter, say half a dozen, and then place it on a place of the edges of the vitiligo patch. And if it's a perigraft migration occurs, as well as the graft material is the pigmentation retains, maybe you can take up these patients for further procedures, because saving the time, the cost, everything is very important. I have had patients who have done wrongly in the early days. That Kupner phenomenon has happened not only in the donor area, also in the recipient area. One such is observing the donor area is very important. If the depigmentation is there, then this is not the case for any procedures.
Yes, sir. Thank you. And this moving on to Vijayanand sir, and this you have also covered this topic, topical band pass filter cream. Brand name I'm not supposed to tell in this forum. This is being marketed now. This selective phototherapy, UVB selective absorption. Have your comment on this cream?
It's hardly 6
Alpha
months it is coming to
glucosylate.
that market. Yeah.
One company is marketing this, and it is being widely used now.
I think that blistering reaction is much more common. Much more common. Okay. I do not know because, but I don't use it in the first line management at all.
Okay. And people started using it in the market. I have not used it personally, and as for theoretical purpose, that is why I asked it is, and it seems that it is being very convenient. Comparing to Puvasol, it is being very convenient. So sharing few slides here. I don't know whether I'm this topical band was. This is actually a few points on that. This filters a non-therapeutic UV and UVA radiation, and a combination of this UV absorb. It contains a combination of UV absorbing molecules. Unlike a sunscreen, it have a minimal absorptions around a therapeutic range of 300 to 320 nanometers. So when this is applied to the skin, the cream biases radiation from the sun towards the therapeutic wavelength of 311 nanometers. And how to apply this? The recommendations are, they recommend that it should be applied to the vitiliginous skin thrice a week for at least 12 weeks, and target the area. It should be immediately exposed to sunlight without any lag, unlike topical Puvasol, where we advise a period of 1 hour before exposure to sunlight. And here the recommendation is in the midday time, 11 a.m. to 3 p.m. and for 5 to 10 minutes. They said there is a good repigmentation. Any leftover cream should be washed off with plain water, and so they say that. And this is the property here is it filters almost 95% of harmful UVA and filters 92% of UVB also. And there is a peak at 311 nanometers in 30 minutes of sunlight exposure. And it has been well published in the this article. There is an article on the Indian Dermatology Online Journal in 2019 itself on this product. What is new in Arab and UV? So looks promising, and there are a lot of time is needed to comment on this cream, sir. Moving on to Dr. Parthiban. So WNT signaling agonist in vitiligo. This has been covered by Professor Vijay Anand itself. Your comment on WNT signaling agonist in vitiligo.
Actually, this is going to be a very good one, ma'am, because this VNT pathway itself has got about some 10 genes. But the VNT pathway has been blamed for ectodermal dysplasia, but we have got a skeleton behind that, P63. This P63 is actually the activating factor. And this VNT pathway works along with other genes like this PAX3, SOX10, and MITIF. And these PAX3, SOX10, and MITIF are very much important for the migration of the melanocyte. When we have PAX3 gene defect, we have heterochromia iridis, we will end up with Waardenburg syndrome. SOX10 and MITIF are highly involved in all the Waardenburg syndromes, which means that VNT pathway is very much involved for migration of melanocyte. So if you have a VNT agonist and if you're using it for vitiligo, and if this is going to help the migration of the cells, I think that it should be a beautiful one, because once we use tofacitinib that side, in order for the cells to migrate, the patient can be treated in OPD without even phototherapy. The patient may not need a surgery at all, but it all depends on what kind of gene he inherits. And incidentally, we see that VNT signaling pathway has got a vital role for hair, which means that this VNT pathway is not a small one. This this has got so many that connects the ectodome to the mesodome. So which means that this is going to be a very good molecule if it is going to come, and if you use it therapeutically skillfully, the patient and the doctor will come out of this vitiligo process. I think this will be a good one. I wholeheartedly wish. So happy to hear Dr. Vijay talking about that VNT signaling agonist. A wonderful one, sir. Any topic given to Dr. Vijay, sir, he finishes up 100%. Excellent one, sir. Excellent one. VNT signaling pathway will be a game changer apart from tofacitinib topical for vitiligo if the patient is not affordable for phototherapy or cannot be approached for surgery.
Yeah. Yes, thank you. This WNT signaling and microRNA targets are going to be the future in the treatment of vitiligo. So moving on to Dr. Ravichandran, sir, there's a small case scenario. Ravichandran, sir.
Yes.
Yes, sir. This 25-year-old unmarried girl, she is working in an IT company. She came with an vitiligenous lesions over the left side of the face, extending to the perioral region. She underwent multiple grafting procedures. Previously, microneedling done with the 5FU, suction blister grafting, and they have tried epidermal cell suspension also. She came to us with this lesion. So we have also tried follicular cell suspension, which one also failed. And how to proceed in this? She's very apprehensive. She's very concerned, and both the parents are very concerned about that vitiligo. She's unmarried also. So how to proceed in that case?
Yes,
And she's not responding to topical tacrolimus or pimecrolimus. So how to proceed in that case?
This is anyway. I could see the picture there. There are some small areas of follicular pigmentation. Is there some pigmented macules are there?
That is only that. Okay.
I think a good dermabrasion with a blister roof will be very ideal. Yeah. Okay. Blister roof is the safest one for a small patch, particularly in the lip area. That will definitely give you can also raise blisters in the vitiligo area if you don't want to do dermabrasion, and that will definitely give an excellent result. And of course, my choice here is do a good depth dermabrasion and take an ultra thin and place it. Cellular may not work because another thing is the thickening of the skin due to some phototherapy. There will be a photokeratosis.
Yes, there is mild fibrosis also.
Yeah, that is the reason. That is the reason that it is not getting repigmentation. Perigraft doesn't occur migration of pigments. So what you do, do a good dermabrasion and then plan for a blister graft and ultra thin graft. Avoid cellular grafts. That should improve considerably well.
Okay. Yes, sir. Right now she is on Excimer lamp. We'll see whether she gets any pigmentation or we'll proceed on with the blister graft as you told.
Thank you, do a graft and then proceed with a laser.
Yes, sir. A question to Vijay, sir. This patient, 55-year-old female, she is a known case of vitiligo vulgaris for more than 30 years, involving 80% of the body surface area. Now came with a history of spontaneously appearing hyperpigmented macules and patches over the face and forearm. And she is very concerned about that hyperpigmentation. She wants to remove that hyperpigmentation patches. So, of course, you covered it in your talk. Since for the benefit of the postgraduates on depigmentation, so and who is an ideal candidate for depigmentation, sir?
Yeah, the extensive vitiligo involving more than 50% of the body surface area refracted to treatment and
age, sir?
Age, as you said here, you mentioned 55-year-old. I don't have any experience with this.
Yes, sir.
Molecule.
Yes, sir.
I don't have any experience with this molecule, but this one monobenzyl ether of hydroquinone, they say that has to be applied 3 times daily, and it depends on the site of area. The concentration depends on the site. If it is over the neck, they say that 5%. and if it is trunk 10%, acryl area 20%. And to start with, we have to always go with the lower concentration. Then gradually we have to increase the concentration. And it takes at least 4 months for complete depigmentation. The patient has to strictly avoid sunlight. She has to use sunscreens.
Yes, sir.
Along with that depigmentation therapy, because the sunlight may induce repigmentation, and after complete repigmentation, they have to be on some maintenance treatment twice a week. They have to apply to maintain the depigmentation.
Yes, sir. Ravi sir, have you?
Is there any age restriction for that?
I think it is a patient's choice. That will be the better one for us. Patient's choice.
Patient choice. Ravi sir, your comment
I would
on
like to, I had 2 patients like this wanted me to remove all the pigments. I achieved very good results on 2 patients, and 1 patient, of course, strict sunscreen usage is important, avoiding sunlight. And then I did 532 nanometer Q-switched NDAC on these pigment cells. That was very effective. 20% hydroquinone is also very effective. I think depends upon this 532 will be better than 1064 Q-switched NDAC.
Oh, okay, sir. Okay. Sundari, and moving on to Dr. Parthiban. On this lady, 35-year-old female, she presented to us with a progressively increasing chronic plaque psoriasis and unstable vitiligo vulgaris. She is getting new lesions of both psoriasis as well as vitiligo. So very concerned about both the diseases. How to proceed in that? Yes.
If you ask me, ma'am, I will put my viewpoints for this patient. Since we have got both psoriasis and vitiligo, it means that the TS17 pathway has been stimulated. Her interleukin 17 and interleukin 23 are being stimulated. They are not going to be steroid responsive. So giving pumping steroids in this patient is not a correct one, because this pathway itself is steroid resistant. And they are going to come down and work on the JAK, back through the JAK and then work through interferons. So it is actually a classical interferonopathy. When we say that vitiligo itself is treated by tofacitinib, topical or systemic, we mean that it is already hitting on the interferons. And psoriasis, we know it is already classified as an interferonopathy. We have been using tofacitinib systemic for that. For this patient, if it is going to be a both combination of psoriasis and vitiligo, the choice will be if the patient is, we can give a systemic tofacitinib for both the diseases. If the patient is coming over, it's a fit candidate for systemic tofacitinib, or else we can go for an interleukin 17 or 23 inhibitors like secukinumab. Give a trial. At least if the patient responds with psoriasis, she will have a good response with vitiligo also, because the cytokine profile is like that. I feel that if she is crossing, depending on the availability of the drug as well as the cost effectiveness, secukinumab or systemic tofacitinib along with topical tofacitinib will be the ideal treatment for this child, this patient.
Yes, sir. Yes, this is the next slide. This patient is being treated, as you said. We have choose tofacitinib, and both the diseases got stabilized.
Exactly.
There is
Because
almost
now we have got a group of diseases as interferonopathies. It goes into systemic lupus erythematosus. It goes up to various other autoinflammatory syndromes. So a dermatologist should go beyond TNF, beyond interferons to understand certain patients, because the system of presentation for individual patient is based on the gene defect and the immune manifestation. So the choice of the prescription is based on the clinical morphology and the pattern of cytokine profile in the patient.
Yes. So we tried 5 milligram of tofacitinib twice a day for almost period of 16 weeks, and there is 100% improvement in PASI in psoriasis, and there is almost more than 60 to 70% of the repigmentation in vitiliginous area. Patient is very happy. The other modalities seems to be cyclosporine can be used both in vitiligo and psoriasis also, and apremilast is also can be tried in this patient. Okay. Moving on to yes, sir. Methotrexate is also tried. And since the patient has not completed the family, we deferred methotrexate in this case. And moving on to so Vijay sir, already we discussed the other depigmentation therapy in vitiligo. Besides this monobenzyl ether of hydroquinone and lasers in depigmentations.
Yes, yes. As I said, the monomethyl ether of hydroquinone is
Already you
there.
covered
Yeah,
for
88%.
complete
Sir mentioned in our setup we cannot use that alexandrite laser and ruby laser. Sir said 530 usage laser and of course cryotherapy. So
Yeah.
on 88% phenol they have given, but I don't have any personal experience.
Okay. To Sir Ravichandran, sir. Sir Ravi, sir.
Yeah, yes, sir. Yes.
Yes, sir. So how to approach difficult to treat cases like genital vitiligo, resistant vitiligo, and there is a question from the audience also, acral vitiligo, from your experience, sir.
So very, yeah, good question. Of course, I have faced this difficult
Yes,
vitiligo means the difficult areas, as you correctly said, genital
yes, sir.
vitiligo, particularly the vulval vitiligo. I
Yes,
have
sir.
done a few cases on glands genital vitiligo, very effective results. Eyelid, of course, response is very good. Nasal orifices are very important, very nice. Auricular orifices, of course. The vulval vitiligo, always the best choice will be a cellular graft. Both stable. So stability is very important. If it is very stable, you can plan for a cellular, because these areas do not very compatible with cellular punch grafts or skin grafts. The dressing is very difficult to do that. Number two is we have to acral vitiligo, the fingertip vitiligo. If it is very stable, do a test patch and proceed to do. Acral vitiligo punch skin grafting, mini punch grafting was very, very useful. Dr. Kaushik Lair used to do that from Kolkata. I think that is a little more painful condition, but you can definitely do, like the Satish Sawant used to do a palmar vitiligo. Palmar vitiligo is one such which doesn't respond to anything. If you do a small micro punches, say 1 to 2 millimeter across both the palms, the response is very, very good. If you can take this first textbook of our surgical social cutaneous surgeon, there are a few photographs of a punch skin grafting done on the palmar vitiligo.
Yes,
Of
sir.
course, it all depends upon the stability, and before that, do a test punch. And I think if it's very stable, we can definitely. What is this reason? We need to put some of the autologous melanocytes in this area. By whatever technique you are expertise, you have the experience, I think we should be able to go ahead well in these difficult areas vitiligo.
Okay, sir. To Dr. Parthiban. And coming to the role of diet in vitiligo, the most commonly asked question by our patients, and your comment on herbal supplements. So this has been already dealt by Vijay
Dr.
Anand,
Vijay,
sir.
his
You
told
just your
excellently,
comment.
sir has covered, ma'am. It is
Yes,
starting
sir.
from
Vijay
polymodium,
Anand, sir, covered.
omega-3 fatty acid, he said he should not give because of the anti-inflammatory property. I completely agree with him. Agree with him. But I will add a few points upon these herbal supplements. I am deadly against them because most of them are photosensitizing, and I've seen some of the supplements patient comes in with phototoxic blistering reaction, and the herbal agents they do not know they do not know the level of psoralen they contain. Most of the patients come to us after purchase over the online. They buy it from the online and then they take the supplements. And I know I don't use herbal supplements in my practice at all. I don't use any of the herbal supplements, and I think that it is not needed. I think it is not needed. The good supplements of antioxidants, I think, beautiful one, but herbal supplements, I'm deadly against that. And I've seen, I'm not against. I'm totally against it. I don't use it in my practice.
Yes, sir. This role of vitamin C, especially citrus-containing fruits in vitiligo. So the most commonly asked question, what your comment on vitamin C in vitiligo?
Exactly, ma'am. No, vitamin C is the most powerful antioxidant, and it actually recycles the reactive oxygen species along with vitamin D. So, if you're asking the patient not to take vitamin C for vitiligo, I think it is not correct. Maybe earlier we used to like that, maybe because the lemon, the limonene, has got a phototoxic effect. They take lemon, they have some phototoxic effect. Apart from that, vitamin C, I don't think that it is a contraindication for vitiligo. And
Actually, it's there are some controversies about this role of vitamin C, and it's a paradox also. Sometimes they say that it aggravates the vitiligo, and there are evidences also supporting that. And any diet has an especially our Indian diet
If
rich in
you stop,
curcumin, the turmeric which contains curcumin. They say that it has a protective effect on vitiligo, especially enhances the
curcumin, I agree completely because it has got an effect on nuclear factor kappa B, and the NFKB has got a synergism with tacrolimus. So curcumin, I think it is a good one, but stopping vitamin C for vitiligo, I don't agree at all. I mean, maybe I'm wrong, but I like to stay on my side. Because I've seen that if you don't, I've seen patients, adult patients who have been left alone in the house without fruits, they come with scurvy. I think the scurvy is more dangerous than having vitiligo.
Okay. So, Ravi sir, your comment on vitamin C in vitiligo,
Yeah,
sir.
I completely agree with Parthiban because the childhood vitiligo, no, the parents try to stop this giving them vitamin C or vitamin supplementation. In the long run, no, vitamin C is one of the important agent for hematopoietic as well as collagen formation. We should not do this. Actually, it's not correct. I always advise to take regular, not the overindulgence, but some amount is very important for the development and growth and bone strength.
Especially for, when we need for healing, lysyl oxidase
Yes.
needs vitamin C. Collagen is constantly produced in the body. If you don't give your collagen, we may land up
Yes, very important. As you correctly said, elders, no, this is actually, I don't advise them to stop. It's not that, it's not a correct idea to roll off. We should dissuade the question. Whenever they ask you, sir, what is your opinion on vitamin C? Just forget it, just ignore it.
Actually, that antioxidant effect overrides that skin lightening effect. So should be encouraged.
Yes, sir. Yes, sir. Completely agreed. So, vitamin C supplementation should be encouraged. And
excuse me, ma'am, I want to know the panelist our opinion about this herbal supplements which are sold online without any, so many things are available for herbal vitiligo for click on online, all the herbal products come up for vitiligo. What way should we do for that?
But I have not heard much actually. I don't know. It's news to me that here.
So the people coming from North India purchasing the bottles. I mean, it has been coming. It is coming from north side. Side. All these herbal supplements for vitiligo. 3 or 4 bottles.
I see.
All are purchased online. They are sold in.
Okay. No idea, sir.
Only after seeing them, I stopped prescribing all this. I never used herbals in my life, and I saw that they're causing havoc.
Yes. Okay.
And I had one patient with psoriasis who was on herbal treatment. Recently, the patient was he developed squamous cell carcinoma. After the squamous cell carcinoma was operated, and he said, I took herbal medicine for 20 years from a native medicine. I'm strongly against herbal base.
Definitely, sir. We should not encourage.
Yes, agree with you. And there are a few questions from the audience. There's one interesting question. Ravi sir, can you please take up? Before marriage, bride or bridegroom with vitiligo, how to choose the partners and counseling on marriage? They asked.
Very interesting question, actually.
But it's difficult to answer also, sir.
Yes,
especially
we
in
need
practice.
to, genetic transmission, then the cosmetic disfigurement, and of course, we have seen quite a number of patients who have a family history, parents, children getting vitiligo, but that's a very negligible percentage. I think we should encourage the young girls and boys. I think I have seen many of my patients, boys getting married to vitiligo girls or vitiligo men getting married to vitiligo. But I think as Dr. Praveen from AJS Praveen has used to run a marriage, vitiligo marriage alumni association. But I think we have a support group is available across India. As a dermatologist, and this is because it's not a contagious disease, it is not going to be anywhere issue. I think we always try to explain, and it is left to the choice of the patient.
Yes. And one more question is regarding somebody has asked how to differentiate hypopigmented patches of mycosis fungoides from hypopigmented patches of vitiligo.
I think biopsy is the ultimate now. We do a
Yes,
biopsy,
of course.
I think we do a CD8 PCR.
Yes.
Unless we do that, it is going to be very difficult. It is easy for all the clinicians to miss hypopigmented mycosis. And the other one is hypopigmented amyloidosis. Both are easily missed.
Yes, very important. I have a few patients in the last 1 month, around 3-4 patients with MF in Apollo cancer. I think biopsy is the most important thing. Psoriasis-like lesions, because psoriasis remission exacerbation is there, whereas in the case of psoriasis-like MF, there is no remission and exacerbations. We got to do a biopsy for patches like these, scaly patches, and also hypopigmented multiple. No, because there's only, I have a patient, single lesion, 2 lesions. MF turned out to be MF. I think a biopsy is the most important thing because we have facilities with immunohistochemistry. Of course, T cell rearrangement also we do. But I think biopsy, as Dr. Parthiban said, is a must to save our skin.
Yes, sir. There will be, of course, there will be the gold standard and the confirmatory evidence is biopsy. Clinically also, when there is a multiple hypopigmented patches, when you examine a patient, there will be a plaque also. Feel the skin. There will be some textural changes. Whereas in vitiligo, there will not be any textural changes, and there will be evidence of some microfumnarization in vitiligo, which will not be seen in case of MF. And the recent tools in dermatology, the dermoscopy will also, before biopsy, dermoscopy will also play a role. Whereas in vitiligo, it is stable vitiligo, it is a complete depigmented lesion with the loss of pigment network. If it is unstable, we can see some comet-like lesions and satellite lesions with dermoscopy. And at the border, there will be a slight perifollicular pigmentations and marginal pigmentations can be observed with dermoscopy. That will be absent in case of MF also, clinically to differentiate before taking up the patient for biopsy. And of course, the biopsy is the confirmatory evidence. And
clinically, again,
in our side, we have another 2 diseases which are complicating. Idiopathic gut-type hypomelanosis in children and Bayer spots. I think Dr. Vijay will agree because one of the pediatric children are blamed as vitiligo. They come with idiopathic gut-type hypomelanosis. That is an unaddressed issue, which is very common this side. Most of them are villages.
Yes, sir. There is one condition called progressive macular hypomelanosis in females, particularly young children, which is responsive to this, I think, to minocycline. Progressive macular hypomelanosis due to propionibacterium. They say that it is due to Cutibacterium. And regarding this hypopigmented mycosis fungoides, this is more common in dark skin individual.
Exactly.
And the distribution of the lesion is also different, no? Mostly in the covered areas.
Exactly.
The proximal extremity trunk and this thing and atrophy, telangiectasia, pachyderma, and all those things. But epidermotrophism is very prominent in this type of hypopigmented mycosis fungoides. That's one important this thing.
But these conditions remain for long. You don't need any active treatment. No, you don't go for electron beam or chemo. I think they stay. Professor Patrick always say HFM remains and remains for years together.
Yes,
unless they have a
therapy. We give narrowband ultraviolet B for
that is sufficient. Because they don't go into patch stage or plaque
sometimes
stage.
We can give a course of acetylene in order to save the immune system if possible.
So is it narrowband UV or UVA1, sir, Vijayanand, sir?
Narrowband UV.
NB-UVB.
Yes, sir. But UVA1 is also preferable in mycosis fungoides. Okay. And this is, sir, afomelanotide you have covered in your talk itself. This seems to be a promising newer emerging therapy. And method of repigmentation following any treatment, whether it is a medical treatment or a surgical treatment, what is your observation, sir? Vijayanand sir and Ravi sir, following any treatment, either it is medical treatment or that is like whether it is how does the repigmentation starts? That is also one of the common question asked by the patients.
Marginal, perifollicular, diffuse, and
Yes,
mostly
sir. Yes, sir.
phototherapy, they have both components, both marginal and perifollicular repigmentation with phototherapy.
Oh, yes. So, Ravi, sir?
Yeah, whatever type of vitiligo is the most difficult one to bring back the color. It is not complete generally. It is somewhere there will be isolated macules will be there. And this is the most tricky area. But we generally cover the extensive one, which is cosmetically disfiguring. But so there are patients who have agreed and then continue to. There are patients who have come to us and I ask them, that, no, sir, I not come for vitiligo treatment, sir. I have health other problem. So they are able to adjust to their life in such a way that certain times we are not able to do anything for generalized active vitiligo.
Yes, sir. Sometimes we get hyperpigmentation following either following surgery also, and especially following patients on methotrexate or azothioprine, we get a hyperpigmentation more than the complexion of the skin. That is again worrying for the patients how to tackle that hyperpigmentation.
Most important.
Treatment.
Yeah, because you cannot even use a camouflage cream to hide this. No, the hyperpigmentation you can do, but not for the hyperpigmentation. It's very tricky situation. So that is why I stopped doing thick grafts, ultra thin grafts. So always is the non-cellular grafts are very useful to get a uniform color match. This is one area which I have done earlier, done beautifully well, but the patient says I have got dark patch. So I think that is not very agreeable, particularly on the exposed sites. Very important that our experiences go hand in hand to give the best benefit to the patient at the end of the day.
Yes, yes. And again, you have covered, Vijayanand sir, you have covered. The question asked is phototherapy on psoriasis.
Yes.
Almost you covered, and so there is question on that. So now it is being neglected for psoriasis not being practiced nowadays, especially this photochemotherapy, because of this hepatotoxicity and ocular toxicity and the inconvenience to say there's a. I don't think anybody practices now. And topical Puvasal, regarding topical Puvasal.
Yeah, in the early days of my practice, I have prescribed, but sometimes no, they don't strictly follow that duration of sunlight exposure, and they apply continuously daily, may result in that blister and hyperpigmentation and so on. So, except in a very resistant focal vitiligo routine, I don't prescribe this topical creams, Sorlan creams. Because perilistal hyperpigmentation becomes very prominent, this surrounding area. And they have to, after exposure, they have to strictly avoid sunlight. Those things are there.
It's not possible in our side. Most of them workers, people from villages, exposure to sunlight is so heavy. It's very difficult for us to. We cannot say that. We can just say anything. That's why topical surveillance, we don't write much. We cannot write much here.
Yes.
Thank you.
And are we running short of time? Do we have time?
No, it's I think 3 hours more than I think we should try to come to. Yeah.
There is the most of the questions were on JAK inhibitors only, and another one is shelling. Why is shelling not used or available? From Muralidhar Rajagopal sir. Ravichandran sir, would you like to answer?
Pardon?
Why is shelling, SHELLING, shelling not used or available?
Kelin.
Kelin, it's not Kelling, yes.
Yes, sir, I don't understand properly. Sir, it is Kelling or
KHELLIN, yeah.
Yes, sir, I don't know whether it is spell check or not. Sir, have you used Kelin, sir? Have you used
No,
Kelin?
not yet, not used. But it was there in the literature. One of the topic. Yeah, I have no experience.
Now, Kannan is actually from Caribbean islands of West Indies, not yet marketed in India. The topical Kannan, some of the companies are trying to bring it, but actually there is no approval. I mean, we have not got topical advanced form of Kannan.
Yes. And before concluding, the last is on camouflage, cosmetic camouflage. Ravi, sir?
Yes, very useful, very interesting that this is really given boon to this young people who are affected with facial vitiligo or acral vitiligo, but it stays for only for a few hours, no? So they have to keep repeatedly applying. If we can, it is a very good option actually. For there are areas where you're not able to get pigmentation with medical or surgical. This is the only answer if the patient is disturbed. Any camouflage particularly you can try, and of course even our village people, they used to do a little potassium permanganate thing, no, they apply. The stain remains. So staining these areas by any modalities is welcome for these patients with using a camouflage. But if you can manage one camouflage cream which can remain for at least for few days, I have tried on one topic which I will still in the research line. So that you apply that, it stays for at least a week's time. You can wash your hands, you can wash your vitiliginous area. That is, after applying a camouflage cream, you got to use something else. I will let you know once this has been used well. It's still in the pipeline, but that will be a good boon for all these patients.
Yes, sir. Thank you. Expecting soon. Thank you. And Vijayanand, sir, your comment on camouflage.
Yeah, madam. So I usually refer the patients. So here in Madurai, in the chemical, particular sub is available. Yes, for the exposed site, I recommend, particularly young girls.
Yes. Parthiban?
Yes, I agree with Dr. Vijay. I think except for few people who really want it, some doctors, especially female doctors who are going for work, they all use camouflage technique already by themselves. So we cannot say professional colleagues, சரியா இல்லை இதெல்லாம் போட்டுட்டு போகணும் பேஷண்ட்லாம் பார்க்க முடியல சார் camouflage வச்சுக்கலாம் சார்.
I have a few doctors who try around half an hour to 30 minutes to do this job in the morning hours. It's very, very time consuming. They have to do it in proper way.
Yes. Color matching.
Ultimately, when it affects our own colleagues, we have sometimes, okay, let you have it.
Yes, sir. It is, agree with you. It is a difficult task, almost like takes a bridal makeup, color matching. They have to go in layers, foundations, colors, everything. Agree with you. And,
very interesting that to camouflage, people have tattooed, no, artistic tattoos. I've got huge collection of patients. Excellent. I used to wonder how they do it. They do it in different styles, flowers, whatever it is. They permanently do artificial, so this professional tattoos. They mask the vitiligo.
So since you started with the tattooing, your experience on therapeutic tattooing in vitiligo, sir?
Long ago, centuries ago. I think it should not be done.
Okay.
We don't have proper dye and proper instruments. It can be done because microblading has come. I think we can try if you are an expertise in this. Proper coloring agents are available across the world, but in India, I think it's all not good. It gives you a different shade of. You see the brown color, but you go into the Tyndall effect gives you a dark color, brown, black spots, grayish areas, gray areas.
Yes. Listen to your lectures on tattooing. That you heard that in Stanley you have done some researches. You went to
long back.
Yes. But there are a lot of dyes are now available with almost color matching. But this tattooing lasts only very temporarily. Almost it's 6 months. More than 6. Maximum period is only 6 months.
People use it for lips, and you do get a lip granuloma, tattoo granulomas, and it's very difficult to do procedures following a tattoo of the lips. I find it very difficult to do dermabrasion, and the pigments keep coming because the pigments keep migrating down to the basal layer, then down there. I think I find it very difficult to do a graft or anything like this in the tattooed lip, because it's unsightly when they go for initially they go, but they regret that why they went. But my thing is, I give it to my plastic surgeon for an excision, not a superficial thin graft.
Yes, sir. Completely agree with you. So before choosing the patient, especially the areas done tattooing underwent as not the areas for any surgical procedures, we get failures. So completely agree. That is why this question. And Vijayanand sir, on tattooing and
yeah, madam, I am not doing all those procedures.
yes, sir.
I refer the patient to the practicing hospital.
Okay, sir. Parthiban, tattooing. Do you?
No, ma'am.
Here.
Most of the patients come to me for tattoo removal. I also refer to practicing cosmetologist.
Yes, sir.
I'm against tattoos even for children. Advise them not to go for tattoo at all. One prick for 15 rupees or 25 rupees, then you have to spend 5 lakhs to remove it.
Yes, agree with you, but tattooing is... Yes, sir.
Yeah, we have seen a couple of cases of sarcoidal granuloma in
exactly. So
tattoo.
It's a sarcoidal and sometimes tuberculosis also.
I have a lupus vulgaris report also with Professor Razak.
In that they have got a tongatan. They change this tongatan. I have one patient, lupus vulgaris in the ear.
Yes, sir. I think
nice day today.
Yes, before winding up the panel discussion, Dr. Ravi sir, to comment on the.
We're happy to be a part of this good 3 hours discussion on this very difficult, most yet unexplored, explored topic of vitiligo. The sufferer is the victim here. It can ruin their psyche. It can be a low self-esteem. Divorce occurs following this condition. I think in the future upcoming, as Parthiban said, the biologics, the RX, all these Parthiban, I think new molecules are in the pipeline. So to facilitate, we are looking at it, but how far it is go. But for generalized vitiligo, therapy may be phototherapy and other things. And the small areas, if it's not repigmenting, cellular grafts come to stay. We achieve very good results, staged procedure. Even large areas, you can do 2-3 sittings to make the area much comfortable. And sometimes if you don't want to do a camouflage and focus on childhood vitiligo. Whenever I see a child with vitiligo, I strip the shirt and look for a halo nevus. The halo nevus is very commonly seen in children. Remove that with a punch and throw away the nevocellular or a macular junctional nevi, so that there is no antibody against this nevus cells, so that distal vitiligo do not occur.
I look for lichen sclerosis retropicus, genital area. Most of the children here, male children, come with peripheral LSA.
Very common.
Yes, and that responds to topical calcipotriol or yes, topical calcipotriol and topical tacrolimus works very well in LSA, especially in genital LSA. Vijayanand sir, before winding up the panel discussion, would you like to comment anything?
Yeah, madam, I will always prefer patients with vitiligo over the head and neck. Over the other areas, it is always difficult to convince them. They will always do doctors often go from one area to other area. I advise them to use regular sunscreens, and I counsel them that is very important. What is the cause, and I will explain them detailedly about what is the cause and what are the prospects of the treatment. It is only controllable, and some people, even elderly patients, think that it is contagious. Some people they don't. They will say that grandchildren, they cannot live with grandchildren. So I convince them that it is not contagious. That we have to live with that. That's what only focal vitiligo and localized vitiligo. So I will use this tacrolimus and Generally, I prefer tacrolimus, particularly the head and neck area. But segmental vitiligo and all, I will refer those patients to that dermatologists.
Yes. Yes. Parthiban? Dr. Parthiban?
Nothing more to add on this, sir.
Okay. So I thank the panelists, Professor Ravichandran sir, Professor Vijay Anand, and Dr. K. Parthiban for their valuable contributions in this discussion on vitiligo and day-to-day practice and the practical points. Thank you very much. As it has been said, it's a disease of main of the psychosocial morbidity and cosmetic concern, especially in the childhood vitiligo, females, and before marriage. That only. So the main concern here is cosmetic. That is the and the psychosocial morbidity. Whatever be the counseling, whatever be the method of counseling given, whatever be the acceptance, still there is a reduced self-esteem and withdrawal from the patients into the society, into the moving on. So we should be there to help them to lead a normal life. And so I thank all, and I thank Dr. Annie. So I thank all the panelists for joining today, and I thank the IADVL President Dr. Kalishwaran sir and IADVL Secretary Dr. Annie Flora for giving this opportunity to hold on to this panel discussion. Thank you very much.
Thank you, madam. We had a wonderful and exhaustive session. The panel discussion was really very much practical, I should say. So we really enjoyed the session. Thank you so much. Thank you all for joining. We would like to have a vote of thanks by Dr. Giordani, our Joint Secretary.
Thank you, ma'am. Very good evening to all the delegates, speakers, and executive council members gathered here. I'd like to begin by thanking our president, A.V. Kalishwaran sir, our secretary, Annie Flora ma'am, and Jayanti madam, Dr. Mohan Sundari ma'am, Dr. Saraswati, and Dr. Anandi. I would like to extend a special thanks to our speakers, Dr. Vijay Anand sir, Dr. Mohan Sundari ma'am, Dr. Ravichandran sir, and also special thanks to Dr. Mohan Sundari ma'am for having convened an excellent panel discussion on the topic. I'd like to thank our coordinators from Sun Pharma, Mr. Ajinkya and Mr. G.K. Krishna. And I'd like to extend a thanks for having given me the opportunity to propose the vote of thanks for this event. Thank you, one and all.
Thank you.
Thank you.
Thank you.
You can
Have
go
a nice
out
day.
and